hypodermic needle, insulin needle, biopsy needle, pleural tap needle, ascitic tap needle. By all these have or high quality surgical steel and have high melting point, recycling is costlier than new make. Glass, intact glass is recyclable, but broken glass, it can be recycled, but very costly to do it. Plastic recycling possible, about 7 times we can recycle, but plastic requires hundreds of years for it to become part of us. My friends from Kolar district, please look at is attitudinal change. The challenge, is it in our hands? Please give it a thought. Please give it a thought. Friends, attitude is a threat. Lack of continuous monitoring and surprise inspection by the regulators is also a threat. All of us, we have been trained in biomedical waste management, infection control, and all of us are doing this work. But why this workshop? We can get more information. We can train others, our colleagues and staff once again. We can request Empri to send the slides. We can repeat the training in district hospital, community health center, primary health center, sub-center, private hospitals, laboratories, blood banks. We can repeat this training. ನಾವೆಲ್ಲ ಬೆಳಗ್ಗೆ ಹೇಳ್ತೀವಿ, ದೇವ್ರಿಗೊಂದು ನಮಸ್ಕಾರ ಮಾಡ್ತೀವಿ. ದೇವ್ರಿಗೆ ನಮಸ್ಕಾರ ಮಾಡೋಕ್ ಮುಂಚೆ ಒಂದು ಬುಕ್ ರೆಫರ್ ಮಾಡ್ತೀವ, ಇವತ್ತು ದೇವ್ರಿಗೆ ನಮಸ್ಕಾರ ಮಾಡ್ಬೇಕು ಅಂತ ಮಾಡಲ್ಲ. ನಮ್ಮ ಅಪ್ಪ ಅಮ್ಮ ಏನ್ ಮಾಡಿದ್ದಾರೆ, ಆ ಒಂದು ಸಂಸ್ಕೃತಿ ನಮ್ಮಲ್ಲಿ ಬೆಳೆಸ್ಬಿಟ್ಟಿದ್ದಾರೆ. ಕೋಲಾರ ಜಿಲ್ಲೆಯ ಎಲ್ಲ ಸ್ನೇಹಿತರಿಗೆ ನಾ ಕೇಳ್ಕೊಳ್ಳೋದೇನು ಅಂದ್ರೆ, ಈ ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್, ಇನ್ಫೆಕ್ಷನ್ ಕಂಟ್ರೋಲ್, ಇದನ್ನ ಒಂದು ಸಂಸ್ಕೃತಿ ರೀತಿಲಿ, ಒಂದು ಸಂಸ್ಕಾರದ ರೀತಿಲಿ ಮಾಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯನಾ? ಈಗೇನ್ ಮಾಡ್ತಿದೀವಿ ಅದಿನ್ನೂ ಅಚ್ಚುಕಟ್ಟಾಗಿ ಮಾಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯನಾ? ದಯವಿಟ್ಟು ಯೋಚನೆ ಮಾಡಿ. ಈ ವರ್ಕ್ಶಾಪ್ ನ ಆಬ್ಜೆಕ್ಟಿವ್ಸ್ ಏನಪ್ಪಾ ಅಂದ್ರೆ, ಲೆಟ್ ಅಸ್ ಇಂಟ್ರಾಸ್ಪೆಕ್ಟ್, review current scenario and strengthen strategies to manage biomedical waste and infection control better, not only within the health centers and hospitals, but till it reaches the healthcare common biomedical waste facility. Meet stipulation of the BMW rules 2016 and 2018 amendments and recommendations of the National Green Tribunal. Idu nam kelsa. ಗ್ರೀನ್ ಟ್ರಿಬ್ಯುನಲ್ ಅವ್ರು ಬಂದು ಯಾತಕ್ಕೆ ನಮ್ಮಲ್ಲಿ ತಪ್ಪು ಹುಡುಕ್ಬೇಕು? ನಮ್ ಕೆಲ್ಸ ನಾವು ಮಾಡಿದ್ರೆ ಸಾಲದೆ, ಯಾಕೆ ಬೇರೆಯವ್ರು ಬಂದು ನಮ್ಮ ಕೆಲಸದಲ್ಲಿ ಈ ತರ ತಪ್ಪು ಮಾಡಿದಿರಿ ಅಂತ ಹೇಳ್ಬೇಕು? Recall and list precautions needed in the context of COVID pandemic and such other disasters, such other epidemics. I repeat, introspect, review current scenario and strengthen strategies to manage biomedical waste and infection control both within and outside the healthcare settings. Meet stipulation of the BMW rules 2016, 2018 amendments and recommendations of the National Green Tribunal. Recall and list precautions needed in the context of COVID pandemic and such other disasters. My friends, my request to each and every one of you from Kolar district, please think over, shall we do it at our individual levels very well? Shall I retrain our colleagues? Let us we ourselves be a models and set example. ನಾನು ಕೋಲಾರ ಜಿಲ್ಲೆಯ 30 ಪ್ರೈಮರಿ ಹೆಲ್ತ್ ಸೆಂಟರ್ಗಳನ್ನ 2 ಸಲಿ ವಿಸಿಟ್ ಮಾಡಿದ್ದೀನಿ ಇಮ್ಯುನೈಸೇಷನ್ ಪ್ರೋಗ್ರಾಮ್ ಇವ್ಯಾಲ್ಯೂಯೇಷನ್ಗೆ. ಡಾಕ್ಟರ್ ಬಾಲರಾಜ್ ಅವರು DHO ಆಗಿದ್ರು 2 ಸಲಿನೂ. ಕೃಷ್ಣ ಹೆಂಗಾರ್ ಇದ್ರು ADHO ಆಗಿ. ಈ ಸಂದರ್ಭದಲ್ಲಿ ರಂಗರಾಜನ್ ಅವರು ಚಿಕ್ಕಬಳ್ಳಾಪುರ ಸಬ್ ಡಿವಿಷನ್ಗೆ ಇದ್ರು. ಎಷ್ಟು ಸುಂದರವಾಗಿದೆ ಕೋಲಾರ. ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಇಂದ ಅದನ್ನ ನಾವು ಸ್ಪೈಲ್ ಮಾಡಬಾರ್ದು.
ಎಷ್ಟು ಸುಂದರವಾಗಿದೆ ಬಯೋಮೆಡಿಕಲ್ ಕೋಲಾರ.
ತುಂಬಾ ಸಂತೋಷ ಸರ್ ತಾವು ಹೇಳಿದ್ದು. ಈಗೇನು ಚೆನ್ನಾಗಿದೆ, ಇನ್ನೂ ಹೆಚ್ಚು ಅದನ್ನ ಮಾಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯವೇ ಅಂತ ನೋಡೋಣ. ನಾ ರಿಕ್ವೆಸ್ಟ್ ಮಾಡೋದೇನು ಅಂದ್ರೆ, ಇಡೀ ರಾಜ್ಯದಲ್ಲಿ ಕೋಲಾರ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಮತ್ತೆ ಇನ್ಫೆಕ್ಷನ್ ಕಂಟ್ರೋಲ್ನ ದ ಬೆಸ್ಟ್ ಅಂತ ಮಾಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯನಾ? ನಾ ಇನ್ನೊಂದು 6 ತಿಂಗಳು ಬಿಟ್ಟು ಕೋಲಾರ ಜಿಲ್ಲೆಗೆ ಬರ್ತೇನೆ. ಆ ಟೈಮಲ್ಲಿ ನೀವೆಲ್ಲರೂ ನಾವು ಕೋಲಾರ ಜಿಲ್ಲೆಯಲ್ಲಿ ದ ಬೆಸ್ಟ್ ಇನ್ ಕರ್ನಾಟಕ ಅಂತ ಹೇಳ್ಬೇಕು. ಇನ್ನೊಂದು ವರ್ಷದಲ್ಲಿ ದ ಬೆಸ್ಟ್ ಇನ್ ಇಂಡಿಯಾ ಅಂತ ಹೇಳ್ಬೇಕು. ದಯವಿಟ್ಟು ಯೋಚನೆ ಮಾಡಿ, ಇದನ್ನು ಒಂದು ಸಂಸ್ಕೃತಿ ತರ ಮಾಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯನಾ ಅಂತ. ಸ್ನೇಹಿತರೆ, ಒಬ್ಬ ವೇದಾಂತಿ, ಆ ವೇದಾಂತಿ ಹೆಸರು ಅರಿಸ್ಟಾಟಲ್ ಅಂತ. ಅವನು ಒಂದು ಪಾಯಿಂಟ್ ಹೇಳ್ತಾನೆ, ಏನಂದ್ರೆ ನಾವು ಏನಾದರೂ ಕೆಲಸ ಸರಿಯಾಗಿ ಮಾಡದೆ ಹೋದ್ರೆ ಅದೊಂಥರ ರಿಪೀಟೆಡ್ ಆಗಿ ಅದೇ ಮಾಡ್ತಾ ಹೋಗ್ಬಿಡ್ತೀವಿ. ನಾವು ಕೆಲಸನ ಅಚ್ಚುಕಟ್ಟಾಗಿ ಮಾಡಿದ್ರೆ ಅದು ಒಂದು ಅಭ್ಯಾಸ ಆಗಿ ಒಂದು ಸಂಸ್ಕೃತಿಯಾಗಿ ಬೆಳೆಸಲಿಕ್ಕೆ ಸಾಧ್ಯ. ವಿ ಆರ್ ವಾಟ್ ವಿ ರಿಪೀಟೆಡ್ಲಿ ಡೂ. ವಿ ಬಿಹೋಲ್ಡ್ ವಾಟ್ ವಿ ಆರ್. ವಿ ಆರ್ ವಾಟ್ ವಿ ಬಿಹೋಲ್ಡ್. ಯಾವುದೇ ಒಂದು ಕೆಲಸ ತುಂಬಾ ಅಚ್ಚುಕಟ್ಟಾಗಿ ಮಾಡಬೇಕು, ಎಕ್ಸಲೆಂಟ್ ಆಗಿ ಮಾಡಬೇಕು ಅಂದ್ರೆ ಇಟ್ ಇಸ್ ನಾಟ್ ಎನ್ ಆಕ್ಟ್ ಬಟ್ ಎ ಹ್ಯಾಬಿಟ್, ಬಟ್ ಎ ಕಲ್ಚರ್. ವಿ ಆರ್ ವಾಟ್ ವಿ ರಿಪೀಟೆಡ್ಲಿ ಡೂ. Excellence is not an act but a habit. It's a culture. I request all my friends from Kolar to make biomedical waste management and infection control the best in Karnataka state. Friends, wish you all the best. All the best to the resource persons. Thank you very much, all officers and team from EMPRI. Thank you, friends. Thank you very much.
Thank you very much, Dr. Prithvi sir, for this inspirational speech. Next, now I would like welcome to the next resource person, Dr. B. Ramakrishna Gaur, Professor of Community Medicine, Department of Community Health, St. John's Medical College, Bengaluru, and the next session is on Biomedical Waste Management 2016 overview. Over to you, sir. Sir, slides are not in slideshow mode. Sir, you can start, sir. Yes, sir. Now it's in slideshow mode. You're on mute, sir.
Okay, ಕೇಳಿಸ್ತಾ ಇದೆಯಾ ಇವಾಗ?
ಹಾ ಸರ್, ಕೇಳಿಸ್ತಾ ಇದೆ. ಬಟ್ ಕ್ಲಿಯರ್ ಆಗಿ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ ಸರ್.
Sorry.
ಹಾ ಸರ್. You're audible, sir. Sir, PPTs are not shared, sir.
ಅದರಲ್ಲೇ ಮಾಡಿ. ಯಾಕೆ ಬರ್ತಾ ಇಲ್ಲ? ಇವಾಗ ಬರ್ತಿದ್ದೀರಲ್ಲ? ನಾವು ಇವಾಗ ಕೇಳಿಸ್ತಾ ಇದೆಯಾ ಜಗದಾಂಬ ಅವರೇ?
ಹಾ ಸರ್, ಕೇಳಿಸ್ತದೆ ಸರ್.
ಓಕೆ, ರೈಟ್, ವಿ ಕ್ಯಾನ್ ಸ್ಟಾರ್ಟ್.
ಬಟ್ PPT ಶೇರ್ ಆಗಿಲ್ಲ ಸರ್.
ಹಾ, ಓಕೆ. ಓಕೆ, ಸೊ ನಮಸ್ಕಾರ ನಮ್ಮೆಲ್ಲ ಪಾರ್ಟಿಸಿಪೆಂಟ್ಸ್ಗೂ ಕೂಡ. ಪೃಥ್ವಿ ಸರ್, ಥ್ಯಾಂಕ್ಸ್ ಅ ಲಾಟ್ ಸರ್ ಫಾರ್ ನಮ್ಮ ಕೋಲಾರ್ನ ಸೆಷನ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಿಕೊಟ್ಟಿದ್ದಕ್ಕೆ ಇವತ್ತು. ಸಾರಿ, ಸ್ವಲ್ಪ ನಮ್ಮ ಆಡಿಯೋ ಅಲ್ಲಿ ಇಲ್ಲೇನೋ ಇಶ್ಯೂ ಇತ್ತು, ಬಟ್ ನೌ ಇಟ್ ಇಸ್ ಅಡ್ರೆಸ್ಡ್. ಸೊ ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಕೂಡ ನಮಸ್ಕಾರ. ನಾನು ಡಾಕ್ಟರ್ ಬಿ ರಾಮಕೃಷ್ಣಗೌಡ್ ಅಂತ. ನಾನೊಬ್ಬ ಇಲ್ಲಿ ಒನ್ ಆಫ್ ದ ಸಂಪನ್ಮೂಲ ವ್ಯಕ್ತಿ. ನಾನು ಒನ್ ಆಫ್ ದ ರಿಸೋರ್ಸ್ ಪರ್ಸನ್. ಮೈ ಅದರ್ ಕಲೀಗ್ಸ್ ಆರ್ ಲೈನ್ಡ್ ಅಪ್. ಡಾಕ್ಟರ್ ಸುಮನ್, ಡಾಕ್ಟರ್ ಅಕ್ಷಯ ಅವರೆಲ್ಲರೂ ನನ್ನಾದ್ಮೇಲೆ ಮಾತಾಡ್ತೇನೆ. ನಾನಾದ್ಮೇಲೆ ನನಗೆ ಕೊಟ್ಟಿರುವಂತ ಜವಾಬ್ದಾರಿ ನಿಮ್ಮೆಲ್ಲರ ಹತ್ರ ಚರ್ಚೆ ಮಾಡೋದಕ್ಕೆ ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ರೂಲ್ಸ್ 2016 ಅಂಡ್ ತದನಂತರ ಬಂದಿರುವಂತಹ ಸ್ವಲ್ಪ ಅಮೆಂಡ್ಮೆಂಟ್ಸ್ ಬಗ್ಗೆ ನಿಮ್ಮ ಹತ್ರ ಚರ್ಚೆ ಮಾಡೋಕ್ಕೆ ನನಗೆ ಮ್ಯಾಂಡೇಟ್ ಇದೆ. ಸೊ ನಾನು ಈ ರೂಲ್ಸ್ ನ ಆದಷ್ಟು ಸಿಂಪ್ಲಿಫೈ ಆಗಿ ನಿಮ್ಮ ಹತ್ರ ಎಲ್ಲರ ಹತ್ರ ಡಿಸ್ಕಸ್ ಮಾಡೋಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡ್ತೀನಿ. ವೈಲ್ ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಗೊತ್ತಿರುವಂಗೆ ಸುಮಾರು ಗವರ್ಮೆಂಟ್ ರೂಲ್ಸ್ ಅಂಡ್ ರೆಗ್ಯುಲೇಷನ್ಸ್, ಯು ನೋ ಹೌ ದೇ ಆರ್. schedules ಅಂತಾರೆ, ಪಾಯಿಂಟ್ ಆಫ್ಟರ್ ಪಾಯಿಂಟ್ ಇರ್ತದೆ. ಸೊ ಐ ವಿಲ್ ನಾಟ್ ಗೋ ಇನ್ ಟು ದಟ್ ಡೀಟೇಲ್, ಬಟ್ ಸರ್ಟನ್ಲಿ ವಾಟ್ ಯು ಕ್ಯಾನ್ ಎಕ್ಸ್ಪೆಕ್ಟ್ ಫ್ರಮ್ ದಿಸ್ ಸೆಷನ್ ಈಸ್ ದ ಟೇಕ್ ಹೋಮ್ ಮೆಸೇಜಸ್ ಫ್ರಮ್ ದೀಸ್ ರೂಲ್ಸ್. ಈ ರೂಲ್ಸ್ ಅಲ್ಲಿ ನಮಗೆ those of us who are at the grassroots level, ನಮ್ಗೆಲ್ಲರಿಗೂ ಕೂಡ ಏನು ನಮ್ಗೆ ಶೇರ್ ಆಗಿಲ್ಲ ಇನ್ನು.
ಸ್ಕ್ರೀನ್ ಶೇರ್ ಆಗಿದೆ ಸರ್.
ಸ್ಕ್ರೀನ್ ಶೇರ್ ಆಗಿದೆಯಲ್ಲ?
ಹಾ ಸರ್, ಸ್ಕ್ರೀನ್ ಶೇರ್ ಆಗಿದೆ.
ಸರಿ. ಸೊ ನಮ್ಗೆ ವಾಟ್ ಇಸ್ ದೇರ್ ಇನ್ ಇಟ್ ಫಾರ್ ಅಸ್, ವಾಟ್ ಆರ್ ದ ಟೇಕ್ ಹೋಮ್ ಮೆಸೇಜಸ್, ಅದರಲ್ಲಿ ರೂಲ್ಸ್ ಅಲ್ಲಿ ಅಡಗಿರುವಂತ what are the few things which are of immediate implication and of relevance to us, for all of us who are working at the grassroots level. ನಾವೆಲ್ಲ ತ್ಯಾಜ್ಯವನ್ನು ಜನರೇಟ್ ಮಾಡುವಂತ ಹೆಲ್ತ್ ಕೇರ್ ಪರ್ಸನಲ್, ನಮ್ಮ ವೆಟರ್ನರಿ ಕಲೀಗ್ಸೇ ಆಗಿರ್ಲಿ ಅಥವಾ ನಮ್ಮ ಆಯುಷ್ ಕಲೀಗ್ಸೇ ಆಗಿರ್ಲಿ, and all of us who are in the allopathic medical institutions, we are all the generators. Primarily 95% of us are the generators of waste. So what is there in the rules which is of relevance to us? What are the lessons that we can learn? What are the guidelines that we have from the rules? And what is that we have to implement on the ground? What is the rules expecting from us? ಅನ್ನೋದನ್ನ ನಾನು ನಿಮ್ಮ ಹತ್ರ ಎಲ್ಲರ ಹತ್ರ ಶೇರ್ ಮಾಡ್ಕೊಳ್ಳೋಕೆ ಪ್ರಯತ್ನ ಪಡ್ತೀನಿ. And questions are most welcome. We will take questions at the end of the session. So ದಯವಿಟ್ಟು ನಿಸ್ಸಂಕೋಚವಾಗಿ ಎಲ್ಲ questions ನೀವು ಕೇಳಿ. I have another one small personal note. ಕೋಲಾರ್ ಜಿಲ್ಲೆ ಸರಿ ಹೇಳ್ದಂಗೆ ನನಗೂ ಕೂಡ ತುಂಬಾ ಇಟ್ ಈಸ್ ಕ್ಲೋಸರ್ ಟು ಮೈ ಹಾರ್ಟ್, ಬಿಕಾಸ್ ನಾನು ಕೋಲಾರಲ್ಲಿ ದೇವರಾಜಸ್ ಯೂನಿವರ್ಸಿಟಿಯಲ್ಲೇ ನಾನು ಓದಿದ್ದು. ಮೈ ಫಾದರ್ ಹ್ಯಾಡ್ ಲಾಟ್ ಆಫ್ ಫ್ರೆಂಡ್ಸ್ ದೇರ್. ಈವನ್ ನೌ some of my best friends are there in Kolar. Some of them in Kolar, and most of them are in the other end of the state, that is in Bijapura district. So Kolar is very, very close to our heart. Sir ಹೇಳ್ದಂಗೆ Kolar probably one of the few places in our state which finds presence in even in the mythological our mythologies. ರಾಮಾಯಣದಲ್ಲಿ ಸುಮಾರು ರೆಫರೆನ್ಸಸ್ ಇದೆ ಟು ದ ಕೋಲಾರ್. ಸೀತಾ ತಾಯಿ ಅವರು ಅಂಡ್ ಲವಕುಶ ಅವರು ನಮ್ಮ ಅವನಿ ಬೆಟ್ಟದಲ್ಲಿ ಅಲ್ಲಿ ಅವರು ಸ್ವಲ್ಪ ದಿನ ಇದ್ದಿದ್ದು, ಇದೆಲ್ಲ ನಮ್ಮ ಈಸ್ಟ್ ಡೋರ್ ಆಫ್ ದ ಕರ್ನಾಟಕ, ಮೂಲ ಬಾಗಿಲು. All these things are very, very, very close to our heart, and like Sir said, it's a beautiful district with lot of potential. And Bengaluru hatra iro karanದಿಂದ there are lots of things that we can do in Kolar. So friends, please take it up as a challenge. Prithvi sir ಹೇಳಿದ್ದು, and let's make Kolar one of the best districts with regards to biomedical waste management. So friends, ಒಂದು ನಿಮಿಷ ಫ್ರೀಸ್ ಆಗಿದೆ. ಓಕೆ, ಚೇಂಜ್ ಆಗಿದೆಯಲ್ಲ ಸ್ಲೈಡ್?
ಸರ್ ಸ್ಲೈಡ್ ಚೇಂಜ್ ಆಗಿದೆ.
ಸರಿ, ನಂದು ಪರಿಚಯ ಆಲ್ರೆಡಿ ಮಾಡಿಕೊಟ್ಟಿದ್ದಾರೆ. ಸೊ ನಮ್ಮ ಸೆಷನ್ ಆಬ್ಜೆಕ್ಟಿವ್ಸ್ ನಾನು ಹೇಳಿದಂಗೆ ರೂಲ್ಸ್ ಅಲ್ಲಿ ನಮ್ಗೆ ಏನು ರಿಲೆವೆನ್ಸು, what is of immediate relevance to those of us who are generators of the waste, and what is that we should do in our healthcare facilities for managing the waste ಅನ್ನೋದನ್ನ ನಾವು ಡಿಸ್ಕಸ್ ಮಾಡಿ we will achieve these objectives. Now friends, whenever we talk about biomedical waste management, it is management and not disposal. It is not biomedical waste disposal. So I have a humble request to all of us here that whenever we talk about biomedical waste, we'll talk in terms of biomedical waste management. So when we say management, it is a whole science and processes and the systems and the SOPs involved ಆಗ್ತಿದೆ. Disposal andre, it is only one step in waste management. So whenever we talk about biomedical waste, we can't dispose biomedical waste without talking about its management. So as simple as that. So when we talk about management, very, very important, friends. I keep on telling this probably to the extent of boring many of my resource persons as well. One of the first steps in waste management is we understanding what is the biomedical waste item I am generating as a nurse, as a Ayush practitioner, as a veterinarian, as a veterinary assistant, or as a laboratory technologist, or as a operating surgeon. What is, I have to know what is the waste item I'm generating. I had anesthesiology colleagues in St. John's Hospital who said, Ramkrishna, we have this item that we generate, we have this needle we generate, and you're all segregation of waste. ನಾನು syringe ಇಂದ separate ಮಾಡೋದು ನೋಡ್ಲಾ? All these questions were asked. I had one of our senior most faculty surgeons in St. John's, who is still the doyen of plastic surgery, who was our ex-CM, CMS, Chief of Medical Services or Medical Superintendent, who made visit in his office and said, no, how to now segregate the waste, Ram? What should I do? When I'm doing the surgeries, my surgeries take a lot of time, and there is a scalpel blade. Then I keep telling my anesthesiology colleagues to to sedate the patient. They will be generating needles. Now it is so difficult for us to put these needles into the waste shop containers. Where do we go looking for a waste shop container? Our office alli on ella ittu nange kelidru prashne. So what did we do? We got our engineering department, operation theater allene ನಾವು ಟ್ರಾಲಿನ ಸ್ಪೆಸಿಫಿಕ್ ಆಗಿ ಡಿಸೈನ್ ಮಾಡಿಸಿ ಅದಕ್ಕೊಂದು ಹುಕ್ ತರ ಒಂದು ಕ್ಲಾಂಪ್ ತರ ಹಾಕ್ಸಿ ವೇಸ್ಟ್ ಶಾಪ್ ಕಂಟೈನರ್ ನ ಅದರಲ್ಲಿ ಇಟ್ವಿ. So what I'm trying to say, friends, is it is possible. Sir said, Prithvi sir said, biomedical waste is everything about that attitude, and our systems, our guidelines, everything will fall into place when we have the right attitudes. It is not much more about that much about the waste containers. It is about attitudes. So that's why I'm giving this example of an attitude. An attitude determines the success of a system, a success of a management process. So that attitude is very important. So coming back to the point I was trying to say, mention. So it's very important for us generators to understand the waste item I'm generating. A needle, it's a metal, it is a sharp, it can prick. Along with the prick, it can give an injection. Apart from visible injury, of blood coming out. It can also, along with that injury, it can also give me an infection. That infection can be hepatitis B, C, or HIV infection. Oh, it's sharp. It's a metal. There is a syringe. Oh, syringe. Potential for misuse and reuse by unscrupulous people. Therefore, I should not just throw a syringe outside my hospital like the way it used to happen a couple of years back. I have to ensure that the syringes are safe and secured, are managed safely and secured in the red color coded containers, and wherever possible, shred them within the institution, or if not, hand it over securely safely to the common biomedical waste treatment facility. And in our common biomedical waste treatment facility, they have beautiful autoclaves, and followed by autoclave, they shred it. And I have witnessed even in Kolar this during one of my visits to the common treatment facility. So a plastic, it is a syringe, it is a plastic, it has a potential for misuse and reuse. So therefore, we have to be that much more conscious about its management. Then being plastic, it has potential for recycling. So therefore, if we manage properly, if we autoclave, if we shred, and if we identify a plastic waste recycler, we can get it recycled safely, which will sustain our environment. Sustained environmental management. One aspect is we ensuring that the waste, so-called waste that we generate for our life processes, do not end up in the river bodies and in the soils and in the hills and everywhere. They are safely reintroduced back into our lives to enable life to continue safely. That is everything about, that is what sustainable environmental management is all about. So safe recycling is possible with plastic syringes, but that will happen only when we segregate. So friends, knowing the waste item that I'm generating, what is it? What is its character? What is its material? Whether I can recycle it, whether I should scientifically, whether it is incinerable, or is it required for me to shred it, or is it okay if I just segregate, disinfect, and hand it over? It will start striking us the moment we start talking about what is that item I'm generating. So understanding the character of the waste that we generate is the first step in management. Then follows segregation. Only when you understand this character, you think about its segregation. Then segregation. Then containment. Oh, what is a container I should have? Oh, it should be, of course, color coded. It should, of course, be lined with polythene liners with biohazard symbol. If it is waste sharp, oh, there has to be a biohazard and waste sharp sticker ಆಗಿರಬೇಕು ಅದರ ಮೇಲೆ, puncture proof container ಆಗಿರಬೇಕು, and better still if it is preloaded with the disinfectant solution. So identify segregation, containment, what for containment, what container, what color coded container, what labeling, what stickers is another question. Then in-house transportation, temporary storage points. Temporary storage point is not dumping all the waste in one room that is available in the backyard of the hospital. No, the biomedical waste rules specify how the storage should be. Idellanu kuda management, friends. So it is biomedical. The point here is it's biomedical waste management and not disposal. Please, it is my humble prayer to all of you. Always speak in terms of biomedical waste. I will not overemphasize on this. I have already mentioned every waste, medical waste that we generate while taking care of the health of the human beings or our livestock is deemed to be biomedical waste. It can be a single needle in a primary health unit or in an outreach camp. Even if we are giving one injection, one needle, that is a biomedical waste that we are generated while taking care of a patient there in the outreach camp. Okay, so biomedical waste encompasses every waste that we generate while taking care of the health of the human beings and animals, wherever it is, in the large institutions, the regional institutions, medical college hospitals, veterinary universities, or Ayush universities, or Ayurveda clinics, wherever, including the waste that we generate while conducting research, like the way it happens in clinical research organizations. Long time back, our research institute asked me and got their research facility assessed for biomedical waste. Never did I expect that they would have taken it so seriously. So one half day, full day I had to spend. While I did the assessment, I also trained them. So it all fell, and it helped them when this funding audit companies that give contracts for research to these organizations come and audit. They were impressed with the systems they had in place. So all of this is biomedical waste, friends. Then whom does this rules apply? It applies to everybody, from a single doctor, Ayurveda, Ayush clinic, to a large medical college hospitals, which employs about 350 doctors. It applies to everybody. It applies to the floating health units on the rivers and on the seas. It applies to our outreach immunization camps and the medical camps that we do. Ivaga pandemic recede agide. Already we are beginning to be bombarded with requests for a medical camp here, a medical camp there. So alli now generate ಮಾಡ್ತಾ ಇರುವಂತ waste nu kuda it comes under the purview of the biomedical waste rules, and therefore we have to manage it accordingly. So all rules apply to everybody in the nook and corners of this great country. Even if it is one syringe that is generated by that hospital has to comply with the rules, and they have to have an authorization to generate that one needle or one syringe. Right? Like I mentioned, friends, this biomedical waste rules has many schedules. Basically, there are 4 schedules. Each of these schedules talk about the categories of the waste, the color codes, ಯಾವ ತರ incinerate ಮಾಡಬೇಕಾ, autoclave ಮಾಡಬೇಕಾ, shred ಮಾಡಬೇಕಾ, disinfectant solution use ಮಾಡಬೇಕಾ. All these things are a part of this schedule. And what is the labeling process anta nimge easy agli anta I have put the schedules like this. The key definitions are only one point I have to mention to you. All of us are authorized persons for generating waste. So that means we are liable for compliance, and we are liable for scrutiny and fines as well if need be. So let's not be under the impression that, oh, it's only our director who's going to be in trouble, or medical superintendent who's going to be in trouble, or head of the department who's going to be in trouble. No, friends, all of us are deemed to be generators of biomedical waste, and we fall under the category of authorized persons, and including our common treatment facility friends, they too also come under the purview of these rules, and avrigene on specific mention madinu kuda rules agide. So basically all of us are have to comply with the rules, and we are accountable. Then what are the duties of the occupiers of the healthcare facilities? Very simple. I have put these points so that you all can use these slides. Sir has suggested, Dr. Prithvish and Mahesh sir, Kumar Swami sir, the Urella Membri training team has suggested that we should share our slides, and in order that it's easy for you, we have put a few of the slides are little elaborate. You can read, and it's self-explanatory for all of you. So basically, in slide number 9, when we say duties of the occupier, all of us are occupiers. Otherly, we have to have basically a system of managing the biomedical waste as per the rules. Segregation ಆಗಿರಬೇಕು, color coded containers ಆಗಿರಬೇಕು, most importantly ನಮ್ಮೆಲ್ಲರಿಗೂ training ಆಗಿರಬೇಕು, and this is one such effort. Then ನಮ್ಮಲ್ಲಿ ವೇಸ್ಟ್ ನ ಹ್ಯಾಂಡಲ್ ಮಾಡ್ತಾ ಇರುವಂತ ನಮ್ಮ ಸ್ಟಾಫ್ ಗೆ ಆನ್ಯುವಲ್ ಮೆಡಿಕಲ್ ಚೆಕ್ಅಪ್ಸ್ ಆಗಿರಬೇಕು, ಅಂಡ್ ಆ ಚೆಕ್ಅಪ್ಸ್ ಆಗಿರುವಂತ ರೆಕಾರ್ಡ್ಸ್ ನ ನಾವು for scrutiny we have to make it available for our environmental officers and other audit teams which come. So all these things are our responsibilities, friends, including getting our staff immunized. So these points are self-explanatory. I will not waste time reading the points through. You all can read it for yourself. I have simplified and put it here. Similarly, duties of the operators. In this training, we have our Kolar biomedical waste treatment facility. Friends, like we have responsibility, they too have a responsibility for managing the waste that we hand over to them responsibly. They too are expected to segregation stream. The red bags and ನಾವು ಹಾಕಿರುವಂತ ರೆಡ್ ಸ್ಟ್ರೀಮ್ ಅಲ್ಲೇ ಹೋಗ್ಬೇಕು, ಯೆಲ್ಲೋ ಸ್ಟ್ರೀಮ್ ಅಲ್ಲೇ ಹೋಗ್ಬೇಕು. ವಾಟ್ ಡು ಐ ಮೀನ್ ಬೈ ಅದೇ ಸ್ಟ್ರೀಮ್ ಅಲ್ಲಿ ಹೋಗ್ಬೇಕು? ಇವಾಗ ಹಾಸ್ಪಿಟಲ್ ಬಂದ್ಬಿಟ್ಟು ಯಾವ್ದೋ ಟ್ರ್ಯಾಕ್ಟರ್ ಹಾಕೊಂಡು ನಾವು ಸೆಗ್ರಿಗೇಟ್ ಮಾಡಿರುವಂತ ತ್ಯಾಜ್ಯನ ಯೆಲ್ಲೋ ಬ್ಯಾಗ್ ಒಂದ್ರ ಮೇಲೆ ಒಂದು ಹಾಕಿಬಿಟ್ಟು ತಗೊಂಡು ಹೋಗೋಲ್ಲ. Biomedical waste treatment facilities are expected by the rules to see that they have a dedicated fabricated vehicle to collect the waste in a segregated way only. So a vehicle alli there will be one dedicated slot or a chamber only for yellow, adar pakkake red, adar pakkake blue, adar pakkake waste. So I have one photograph that I will show you, but that's what it is. So they have expected to maintain the chain of segregation chain. They are expected to have quality and standard incinerators or pyrolators, whichever they are using for treatment, including autoclaves and shredders. Adu standards prakara irbeku. And they too also should be ready for scrutiny by the environmental officers whenever they come for inspections. So they too are responsible. And like in the medical institutions, our common treatment facility persons also have to get their healthcare staff a medical checkup done every year, and they have to keep their medical records for available for scrutiny. And this is the penalties for non-compliance, friends. So, sir, now easy we have example of an IAS officer being pulled up for compromising the biomedical waste management about 10 or 12 years back. We know one corporate hospital wherein the medical administrator of the hospital was put into trouble because the hospital was not managing the biomedical waste. A team number of our hospitals got notices from the pollution control board. If our pollution control board wants, most of the hospitals will be in trouble. But to speak to our KSPCB officials and our environmental officers at the zonal level, in fact, at St. John's, I'm very happy to share, at our request, our zonal officers came and they were a part of our training team. They trained our staff also along with us. So they are facilitating us, they are supporting us. So let's use this opportunity and let's none of us suffer the ignominy of being fined or being put into behind bars for non-compliance with biomedical waste rules. But for the sake of completion of this discussion, I have put the penalty provisions that are there for compromising biomedical waste. Let's take this very seriously. And like I will go by the spirit of what Sir mentioned, let's not do this for the sake of the rules. Let's do this for the sake of the health of our own staff. One of the biggest beneficiaries of biomedical waste management will be Parisara. God bless, it will happen. But the biggest beneficiaries will be our own healthcare staff. And we have a team number of examples on this training program. I have my colleague, Dr. Suman also, and Akshaya also. Wherever we have done training programs on medical waste and hospitals and other systems place, the immediate beneficiaries are our housekeeping staff. In fact, I have the personal experience of our housekeeping staff coming and Doctor, you are training tumba serious ampoule cutter use needles na segregate nam responsibility segregate so and therefore needle chichilla on the broken ampoule cut. So the biggest beneficiaries are us only, our own staff. So let's do that for the purpose of sensitivity, and most importantly, if I have to put it from on a technical terms, for the sake of occupational health. And biomedical waste is everything about, friends, two things. Biomedical waste is not about color codes, containers, and incinerators. Biomedical waste primarily is about occupational health. Primary and secondly, it is about infection control. If we have good biomedical waste systems in place, it will also bring down our hospital-acquired infections. 100% guarantee it will happen, because our talk of understanding the waste items, segregation, disinfection, etc. So what happens? It will have lateral cascading effects on other things falling into place. They will start about, oh, I have to do this. No, let me not generate this waste. Oh, you are using antibiotics left, right, and center. Let there be some sanity in the way we are using our antibiotics. Everything undukundu link agide, friends. So biomedical waste, again, repeating this again. Dayavitu biomedical waste, let it not be narrowed down to a discussion on color codes and containers and incinerators. No, friends, please. Let it be, we talk biomedical waste because it addresses occupational safety, and number two, it addresses infection control, all of which are very important for our healthcare ecosystem. Now, composition of biomedical waste. You all know this slide. I will not mention, I will not spend too much of time on it. If a hospital generates about 100 kilos of waste, about 15% of that will be infectious and hazardous. And the rest of the waste actually is like general waste, right? So this 15% of waste will remain infectious only when we understand the waste item and have systems in place. And 15% will remain as only 15%. It will not end up as 100%. But right now, what is happening in many places, even now, friends, is this 15% of infectious waste gets mixed with the rest of the 85% of the non-infectious or general waste and makes all of that waste as infectious waste. So how do we address it? We can address this by attitude and practice. Okay, if you have the attitude and if you have the practice, we will end up with a challenge of only managing 15% of the waste. So, and all of you will agree with me when I say it is easy to manage 15% rather than 100%. So for that to happen, biomedical waste management is important. And a discussion on biomedical waste management is incomplete if we do not talk about solid waste management rules. The 85% of the waste that we are generating, leaving out the 15% of the waste, the other remaining 85% of the waste has to be managed as per the provisions of the solid waste management rules 2016. Biodegradable waste, the so-called wet waste, should be segregated from the non-biodegradable waste or the dry waste as per the provisions of the solid waste management rules. So please understand solid waste management rules and ensure that the general waste is managed as per those rules. Now, I spoke about Schedule 1, Schedule 2, Schedule 3 and Schedule 4 plus also the penalty provision. ಅದೆಲ್ಲಾನು ಇದೊಂದು ಸ್ಲೈಡ್ ಅಲ್ಲಿ ಸಮ್ಮರೈಸ್ ಆಗಿದೆ. In general, when I walk into the hospital, apart from the records and reports, what is that we should see? So what is that is expected? It is expected that the waste in the hospital is segregated into yellow, red, blue, and metal waste sharp containers, and the general waste is managed as per the second row in your slides. The biodegradable waste into the green and the non-biodegradable dry waste should go into the blue. And the artha enu ellanu a blue color alli haakudalla. Newspapers will be automatically segregated. Other plastic retrievables will be segregated. So that is another altogether different discussion. You all know. I will not repeat that thing again. Now coming to the containers. So yellow container alli incinerable waste hogutte, and technically in a hospital, for example, if you walk into our MS Ramaya hospital or KIMS hospital or any our Kolar Medical College, Devarajan Medical College hospital, you can expect to see 3 different types of yellow containers. The first yellow container will have cotton, dressing, sanitary napkins, human anatomical waste, animal waste, tumor tissues, and including POP will be in one yellow container. These hospitals, there is a possibility that they will also have a second yellow container, a separate second yellow container. The separate second yellow container is meant for pharmaceutical waste. And in hospitals such as mine at St. John's or Ramaya or in Kidwai Memorial Institute of Oncology, since they have oncology wings, those hospitals may have even a third waste container, friends. Third yellow container. The third yellow container is expected to have cytotoxic or genotoxic drug waste. Sarina? So, but it doesn't matter. The waste in the first container, waste in the second, that is the pharmaceutical expired drugs are partially used or other such pharmaceuticals or drugs, or the cytotoxic drugs. The final endpoint treatment for this waste is incineration only. That as generators of waste at the grassroots level, let's not go into deep into it. Our mandate is segregate. You are generating it, segregate. As to how they will incinerate these 3 different categories of waste which is there in the containers, in the yellow bags, let's not break our head. That our pollution control board officials and our common treatment facility friends, they have a system in place and they will manage it with good standard quality incinerators. But the take home message for all of you is, when we talk about yellow waste, you will see that there is a possibility that a given hospital will have 3 yellow containers. First yellow container for cotton dressings, ityadi. Second, only for pharmaceutical waste, expired or partial use drugs. And the third container for cytotoxic or genotoxic drugs. So this is about the first containers. And mind you, friends, we also have the blood bags. Yesterday, I was at our blood bank talking to my colleagues at the blood bank, trying to address few issues there. So blood bags are unique waste, which again have to go into the yellow. But the only difference is blood bags must be autoclaved first, and tadanantarane it should go into the yellow bags. That is the only plastic. Blood bags are the only plastics which are allowed to go into the yellow. Otherwise, into yellow, no plastic, no metal, no glass. Right? Only exception is blood bags. And how is that blood bags can go into the yellow container? Only after they get autoclaved. They are expected to put into a yellow container or in the yellow polythene liner, which will be autoclaved and will be shredded. So please keep that in your mind. ಸುಮಾರು ಜನ ಕೇಳ್ತಾರೆ, ಸರ್ ಬ್ಲಡ್ ಬ್ಯಾಗ್ಸ್ ಏನ್ ಮಾಡೋದು ಅಂತ. ಬ್ಲಡ್ ಬ್ಯಾಗ್ಸ್ ರೆಡ್ ಗಲ್ಲ, ಬ್ಲಡ್ ಬ್ಯಾಗ್ಸ್ ದೋ ಇಟ್ಸ್ ಪ್ಲಾಸ್ಟಿಕ್ ವಿಲ್ ಗೋ ಇಂಟು ಯೆಲ್ಲೋ. ದಟ್ಸ್ ಓನ್ಲಿ ಎಕ್ಸೆಪ್ಷನ್. Including we also have very infectious waste from microbiology. There also, the microbiology lab in St. John's, we autoclave it and hand it over. And that's the same case in many places as well. So this is a second yellow container that I was talking about, containing only the pharmaceutical waste. And the third container is unique. Not many hospitals will have, because all the hospitals do not have oncology services. So if at all we have cytotoxic drugs, the waste container should be yellow container, polythene liner with the C symbol. And coming to the second, red is simple. Red is plastics, only plastics, nothing but the plastic. Red ali bare plastic, no metal, no glass, only plastics and nothing but the plastic. The only plastic item which will not go into the red container is the blood bags, which will go into the yellow container. Otherwise, all plastics into red color-coded containers. This is autoclaving of the infectious waste at our microbiology department. And after autoclaving, we hand it over for storage, and from storage, it will be picked up by Maridi. They again will autoclave it and shred it. So the third container, friends. So we have finished yellow, we have finished red. Now we are coming to the blue container. Like yellow, we may have, a hospital may have 2 blue containers. One blue container only for glass waste, second blue container for metal implants and prosthetics. Metal implants and prosthetics, again, yellow hospitals barala, only trauma care institutions where there is a active, and other institutions where there is an active orthopedics department. ಅಲ್ಲಿ ಮಾತ್ರ ನಿಮಗೆ ಮೆಟಲ್ ಇಂಪ್ಲಾಂಟ್ಸ್ ಬರೋ ಚಾನ್ಸಸ್ ಇದೆ. ಅದರ್ವೈಸ್ ಮೆಟಲ್ ಇಂಪ್ಲಾಂಟ್ಸ್ ಸುಮಾರು ಕಡೆ ಬರಲ್ಲ. ಅಕಸ್ಮಾತ್ ಮೆಟಲ್ ಇಂಪ್ಲಾಂಟ್ಸ್ ಪ್ರಾಸ್ಥೆಟಿಕ್ಸ್ ಏನಾದ್ರು ಇದ್ರೆ, as categorized as waste items, they should go into a second blue bag. So the first blue bag only for glass, second blue bag for metal implants and prosthetics. And this blue bag should be a thick, corrugated, leak-proof blue container. And it should be color-coded blue and labeled with biohazard symbol. Photographs ಇದೆ. So this is the metal implants ನಾನು ನಿಮಗೆ ಹೇಳ್ತಾ ಇದ್ದೆ. So glassware into blue containers such as this. ಇಲ್ಲಿ ಈ ತರ ಬ್ಲೂ ಕಂಟೈನರ್ಸ್ ಎಲ್ಲರಿಗೂ ಆಕ್ಸೆಸ್ ಇರ್ಲಿಕ್ಕಿಲ್ಲ, ಬಟ್ ಅದು ಬರುವವರೆಗೂ ನಿಮ್ಮಲ್ಲಿ ಇರುವಂತ ಕಾಟನ್ ಬಾಕ್ಸಸ್ ಯೂಸ್ ಮಾಡಿ, ಒಂದು ಬದಲಾಗಿ 2 ಯೂಸ್ ಮಾಡಿ, ಒಂದು ಲೈನರ್ ಬದಲಾಗಿ 2 ಬ್ಲೂ ಲೈನರ್ಸ್ ಯೂಸ್ ಮಾಡಿ, ಯು ಮೇಕ್ ಇಟ್ ಲೀಕ್ ಪ್ರೂಫ್. But more and more such containers are coming into the market, and the costs also will come down. So till such time, please use the thick kg cardboard containers you have. Go by the spirit of the rules. The spirit of the rules is color code. So if you do not have blue color, pack that these kg cardboard containers with blue Scotch tape. That also becomes a color coded, but label it. like what these people have done in the my right side bottom corner. Puncture proof containers, ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಗೊತ್ತು, ಎಲ್ಲಾ waste shop, metal waste shop should go into a puncture proof container. ನಮ್ಮ ಲಾಸ್ಟ್ ಟ್ರೈನಿಂಗ್ ಪ್ರೋಗ್ರಾಮ್ ಅಲ್ಲಿ ಅವ್ರು ಕೇಳಿದ್ರು, ಸರ್ puncture proof container ಅಲ್ಲಿ hypochloric acid solution ಹಾಕಿ ಇಡಬೇಕಾ ಅಂತ ಕೇಳಿದ್ರು. It's a good practice. It's a good practice. Contain your waste shops in a waste shop container preloaded with hypochloric acid solution wherever possible. It will help the cause. And we have seen that. I am very fond of saying this. So puncture proof container is one very good comprehensive system. Ellanu sigutte adralli. It's I am tempted to use analogy of biryani, so I will not use it. But anyway, waste shop container is a very good system. It's a very packed, comprehensive system for waste shops. One day touch alli, one day person hand alli, we can segregate it, we can contain it, we can disinfect it, and along with disinfection, which we can achieve disfiguration also, because hypochloric acid solution will have hypochloric acid ions, and whenever metal acid falls on metal will get corroded. In our small experiment which we have done in my own department, we have seen that in about 21 days the metal shop starts corroding. Corrode ಆಗಿರುವ ನೀರನ್ನ ಮತ್ತೆ ಯಾರು ಯೂಸ್ ಮಾಡಕ್ಕಾಗಲ್ಲ. So in the hand of one person, in one touch, you are achieving segregation, containment, disinfection, and disfigurement. And tadanantara whole of the waste shop container you can hand it over to common treatment facility. They will manage it further. Don't break your head. So these are the examples of waste shop containers. Little bit of description about it. This is a description on the liners. Now containers get importance ಕೊಡ್ತೀವಿ, polythene liners ಗೂ ಅಷ್ಟೇ importance ಕೊಡಬೇಕು. They should be of a thickness that is prescribed under the rules. ಸುಮಾರು ಕಡೆ our common treatment facility ಅವರೇನೆ facilitate ಮಾಡ್ಕೊಡ್ತಾರೆ. We should have the thickness as prescribed under the rules of certain microns. We should have biohazard symbol, and if it is cytotoxic drugs, we should have a C symbol as well. And the new thing in the rules is every bag that goes out of our hospital should have a barcode or a QPR code. That is mandatory now. Again, we do understand in many places we do not have a barcode system. That doesn't matter. Till such barcode system is implemented in your hospital, please ensure that every polythene liner is has the details of which hospital, which ward, what waste, and what date it is handed over, and the name, short name of the person who is handing over. Adu aglebeku, that is expected. But ultimately, what the rules expect is that we have to have a barcode system in place. And the use of this barcode is, it's like a genetic code. It will tell you if I infrared gun itkonda barcode na nan read madre, or if any of our environmental officers read it, they will know. The moment they read the code, it will tell you, oh, this waste has come from St. John's. It belongs to oncology male wing, and it is yellow color, and it is of this much weight, and it is generated on this data. So that's the beauty of barcode. In fact, at St. John's, we also have gone further into the cytotoxic waste. Actually, rules leave it little broadly yellow, red, and blue on that. But if you want, you can further categorize that yellow as cotton or solid infectious waste, or as pharmaceutical, or as a cytotoxic. But all in all, we have to have barcode. Now, this is what I was mentioning. Our common treatment facility friends will have a system like this, a vehicle, fabricated vehicle like this, which will come and collect the waste in a segregated way only and transport in a segregated way only. And every person, we had one question in, I think in our second or third day, I think Ballarinda ಈ question ಇತ್ತು, ಸರ್ ಒಬ್ಬರೇ ಡಾಕ್ಟರು ಒಂದೇ ಸಿರಿಂಜು ಅವರೂ ಲಿಂಕ್ ಮಾಡ್ಕೋಬೇಕಾ, they also apply for authorization, and they also should link up with the common biomedical waste treatment facility ಅಂತ question ಬಂತು. Yes, you have to, no exceptions. Everybody, single doctor, single syringe generating, and small iron small ball of cotton ball generating institutions also should get authorization, and they have to link up with common biomedical waste treatment facility. ನಿಮ್ಮ ಹತ್ರ ನೀವು ಅವ್ರ ಹತ್ರ ಏನ್ ಫೀಸ್ ಡಿಸ್ಕಸ್ ಮಾಡ್ತೀರಾ ನೆಗೋಷಿಯೇಟ್ ಮಾಡ್ತೀರಾ ಮಾಡ್ಕೊಳ್ಳಿ, ಬಟ್ ಯು ಹ್ಯಾವ್ ಟು. The only exception is the hospitals which do not have an access for linkage to a common biomedical waste treatment facility. Antavarige matra rules alli with a special provision with prior permission of the with the prior permission of the pollution control board, they can have their own waste jar pit done up to the engineering standards which is mentioned in the rules, and also the deep burial pit for containing infectious waste, again done up to the sanitary and civil engineering standards as prescribed in the rules, but with the prior permission of the pollution control board. Only those hospitals can have their own waste pit and deep burial pits. Otherwise, all of us are expected to get linked up to the common biomedical waste treatment facility. Friends, liquid waste has always been a challenge for biomedical waste. So basically, we have to replumb our liquid waste systems in the hospital. Chick hospitals get easy, dod hospitals get now no exception given. We have to have effluent treatment plants, and many hospitals currently have their own effluent treatment plants in place. This is in fact, this is a model which the rest of the country has borrowed. Karnataka Health System Development Reforms Project alli, we had one of our engineers by name Ravi. Our design ಮಾಡಿರೋ description for having a liquid waste management system in place. So you can have this as your reference. These are the few photographs we have taken from our primary health centers of the government, just to show them, to convey to us all that Manasidre Marga. Okay, may not be perfect, but at least we are rendering the infectious liquid waste non-infectious, and that much of risk of infection and hazard we are reducing. We may not be perfect, but we are reducing the hazard and the risk. That is most important. And friends, I have mentioned this already, I will not repeat again. Integral to biomedical waste is health appraisals, immunization of the healthcare staff, training of the healthcare personnel, like what is happening now. Meticulously, this training program is being organized by our training institute. ನಮ್ಮ ರಿಸೋರ್ಸ್ ಪರ್ಸನ್ಸ್ ಎಲ್ಲಾನು ಕೂಡ ಇಮೇಲ್ಸ್ ಬರ್ತದೆ, and on the day of training program, 1 hour before, all of us will get a call from our training unit of EMPRI. Sir, today is your session, sir. Check your systems, check your connectivity. So a lot of effort is being invested. So training, likewise, you all have to invest the efforts for training your personnel at the district level, please. And have a documentation of all of your training programs, the date of training, the participants, the venue of the training, what's the time. Have that as a document. Video clips madi, photographs madi, itkondre when they come for audit or inspection. This is one of the important records that they see, so we are safe. And we have to have an injury record and an accident register as well. Maintain injury record, and mostly it is needle stick injuries. And accident register andre nama trolley ne turn aito, overturn agidhoytu, athwa when that happened, there is a physical injury to the person who is transporting waste, or short circuit aito, athwa in fire accident aito, idellanu kuda accident register alli ನಾವು ಫಾರ್ಮ್ ಇದೆ, and register alli kuda ದಾಖಲಾತಿ ನಾವು ಮಾಡಬೇಕಾಗ್ತದೆ. And other requirements of the biomedical waste rules are, we have to have a hospital infection control committee or a biomedical waste committee, which specifically looks into the rules. As to last Shimoga in the one of our doctors asked, sir, sir, is committee who all can be anta? It depends upon your hospital. Certainly your medical superintendent, if you have a hospital administrator separately, hospital administrator, chief of nursing, or nursing superintendent, heads up, core heads of the department, core departments, surgery agli, ortho agli, athwa ICU agli, select on the 9 to 13 members team na all inclusive team itkonde nimge sulva agtade, but it's left to you all, and you have to please dedicate identify one nodal person. These details are there in the rules, so don't worry. If you look at the rules, it also has a description of this. And this committee has to meet regularly. Minutes of the meeting irbeku, what problems they have identified, and what is the solution, and what is the follow ಮಾಡಿರೋದು ಕೂಡ ಈ ಮೀಟಿಂಗ್ ಅಲ್ಲಿ ಈ book ಅಲ್ಲಿ ದಾಖಲಾತಿ ಆಗ್ತದೆ. And not to forget, amidst all these things, one of the challenges we continue to have and we must accept is waste minimization. while you segregate, while we contain, while we treat with standard incinerators or pyrolators and autoclaving and shredding, etc. One aspect of biomedical waste and waste in general also is waste minimization. ನಾನು ಇಷ್ಟು ವೇಸ್ಟ್ ತ್ಯಾಜ್ಯನ ನಾನು ಜನರೇಟ್ ಮಾಡ್ತಾ ಇದ್ರೆ ಇದನ್ನ ಇಷ್ಟನ್ನ ನಾನು ಯಾವ ತರ ಇಷ್ಟಕ್ಕೆ ನಾನು ಮಾಡಬಹುದು. ಸೊ ಪ್ಲೀಸ್ ಆಲ್ವೇಸ್ ಥಿಂಕ್ ಆಫ್ minimization of waste also as a practice. So friends, I'm coming to the last part of my presentation. The other rules I have mentioned about the solid waste management rules for managing the 85% of the waste. Along with that, we also generate a lot of electronic waste, especially nowadays. So we have to comply with the provisions of the e-waste management rules. We have lots of chemicals that we use. The chemicals that we generate must be managed as per the hazardous waste management rules. And radioactive waste, if at all a hospital is generating radioactive waste, such as oncology hospitals, oncology units, they have to comply with the provisions of the Department of Atomic Energy or Baba Atomic Research Center guidelines. Detailed guidelines ide adu takkange avaru manage ಮಾಡಬೇಕು. So this is a biohazard symbol. Now a series of photographs, friends. Biohazard symbol better. So what we have done in our hospitals is we have a metal waste sharp anta ಒಂದು sticker separate ಮಾಡಿದ್ವಿ, glass sharp anta ಮಾಡಿದ್ವಿ. If possible, do it, but otherwise you at least have to have biohazard symbols pasted on the waste containers and liners. Occupational safety ಬಗ್ಗೆ Dr. Suman and Akshay ಅವರು ಹೇಳಿಕೊಡ್ತಾರೆ details. So this is a picture that captures the basic occupational safety equipment that our people should have. It depends upon the work we are doing. ಅದಕ್ಕೆ ತಕ್ಕಂಗೆ ನಾವು that particular safety measure we have to follow. It's not that anyway, even to go give an injection, I should go in an astronaut suit. That is ridiculous. So standard precautions ನಾವು ಯೂಸ್ ಮಾಡಬೇಕು. Dr. Suman and Akshay are going to talk about it, so don't worry. And sumaru questions bantu COVID-19 waste admele. The principles of managing COVID-19 waste are exactly the same as what I've discussed now. The only difference is na COVID-19 waste ellelli aa tyajya ನಾವು ಜನರೇಟ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ, ಅದನ್ನ ಡೆಡಿಕೇಟೆಡ್ ಕಂಟೈನರ್ಸ್, ಆ ಕಂಟೈನರ್ ಮೇಲೆ ಯೆಲ್ಲೋ ಕಂಟೈನರ್ ಆಗಿದ್ರೆ ಆ ಯೆಲ್ಲೋ ಕಂಟೈನರ್ ಮೇಲೆ ಕೋವಿಡ್ ವೇಸ್ಟ್, ಕೋವಿಡ್ ವಾರ್ಡ್ ಅಂತ ನಾವು ಹಾಕಬೇಕು. And the liners should be double liners. Again, the details, Dr. Akshaya will go into the details of it. So these are the key points that you have to remember: biohazard symbols, good quality containers, no touch containers, and labeling the waste containers as COVID-19 waste for the waste that is coming out of the COVID-19 wards. So this is a trolley. This is a dedicated biomedical waste. ನಾನು ಹೇಳಿದಂಗೆ ಯಾವುದೋ ಮೂಲೆ ಅಲ್ಲಿ ಹಾಕೋದಲ್ಲ. We have to dedicated waste with good illumination, ventilation, secured, and if possible under the CCTV camera. And this is a yellow container with a QPR code or barcode use ಮಾಡಬಹುದು. And this person is handling it and he's reading that, entering the details of that waste into the system. This is how the application is going to be. I understand from our puja and training team that all of our district the training programs have a small capsule on application also. So ದಯವಿಟ್ಟು application ನ ಕೂಡ ನಿಮಗೆ ಈ ಟ್ರೈನಿಂಗ್ ಅಲ್ಲಿ ಇವತ್ತಿನ ಪ್ರೋಗ್ರಾಮ್ ಅಲ್ಲಿ ಡಿಸ್ಕಸ್ ಮಾಡ್ತಾರೆ in a small capsule, so don't worry about it. So this is how it should be storage. This is a waste shop pit, deep burial pit. The engineering details are there in the rules, so don't worry. If at all you have to use, you have to construct according to those engineering details. Solid waste rules kuda now comply agbeku, dry waste and wet waste. So with that I come to the end of my presentation, friends. So these are the few resources that I have used for preparing this presentation. So thank you all very much for your patient listening. If there are any questions based on our training team's suggestion, we'll take that questions either now or at the end of the next two sessions. I leave that to Madam Pooja to decide. But please do ask questions. Don't hesitate. An email is already shared with you. You can write down your questions in the email and send. In fact, we had our IMA colleagues from one of the districts writing us emails and asking us questions, and we have responded also. Don't hesitate to ask questions. Don't hesitate to give in writing your questions. We don't want your name. We don't want your hospital's name. Just give us a question, and our training team will, all of us will make an attempt to give you the answers. But please do ask. So, thank you very much. Thank you. Thank you, Pooja.
Thank you, sir.
Thank you, sir.
Thank
Thank you so much, sir.
Pradhan.
It's a very informative session.
Thank you. Thank you.
Participants can ask questions now.
ಜಗದಂಬ ಅವರೇ,
Hello. Ha sir, ಕೇಳಿಸ್ತಾ ಇದೆಯಾ sir?
ಹಾ
Sir, ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
ಹಾ, ಸ್ವಲ್ಪ ನಾನು ವಾಲ್ಯೂಮ್ ಜಾಸ್ತಿ ಮಾಡ್ಬೇಕನ್ಸುತ್ತೆ.
ಹಾ ಸರ್.
ನಾನು ಮಾಡ್ತೀನಮ್ಮ, ವಾಲ್ಯೂಮ್ ಜಾಸ್ತಿ ಇಲ್ಲ, ನಿಮ್ಮ ಧ್ವನಿ ಕ್ಲಿಯರ್ ಆಗಿದೆ, ವಾಲ್ಯೂಮ್ ಜಾಸ್ತಿ. ಹಾ, ಇವಾಗ ಹೇಳಿ.
Participants can ask questions now.
Participants can ask questions now. Okay,
Ha, sir.
let them ask. No, why I'm saying is some of their questions may be answered in the next presentation itself by Dr. Suman and also by Akshaya. Okay, ask, let them ask. We'll take 1 or 2 questions.
Maybe ಏನು questions ಇಲ್ಲ ಅನ್ಸುತ್ತೆ sir. Ha ma'am, Dr. Manjula Ramaya, you can ask ma'am question now. Sir, next questions ಏನು ಇಲ್ಲ ಅನ್ಸುತ್ತೆ sir. So
ಅದೇ
Okay,
Dr.
sir.
Suman ಅವರು ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಲಿ.
Okay,
Let
sir.
them all gather their
Thank
thoughts,
you.
write down their questions, chat box ಅಲ್ಲಿ ಬೇಕಾದ್ರೆ ಹಾಕ್ಲಿ,
Okay sir, okay.
share ಮಾಡ್ಲಿ.
Okay.
We'll take the questions, no problem. We are here.
Thank-
Our time is there, so please.
Okay sir.
So
Thank you so much sir for
thank you
detailed.
once again, and I'm closing.
Thank you so much sir for detailed explanation about segregation of biomedical waste, storage in designated color bins. Thank you sir. Now I would like to welcome the resource person for the next session on gap analysis on biomedical waste management. Suman ma'am.
Hello, am I audible?
Yes ma'am, you are audible ma'am.
Okay, Dr. Ramkrishna, can I request you to stop sharing, please?
Riba.
Dr. Ramkrishna,
Yes ma'am, you can share now ma'am.
yeah, okay. Are my slides visible
Not yet ma'am.
enough? Enough?
Ma'am, ನಿಮ್ದು ಸ್ಕ್ರೀನ್ ವಿಸಿಬಲ್ ಇದೆ ಬಟ್ ಪಿಪಿಟಿ ಶೇರ್ ಆಗಿಲ್ಲ ಮ್ಯಾಮ್.
PPT share ಆಗಿಲ್ಲ, share ಮಾಡಿದೀನಿ ಈಗ.
It will take some time.
ಸಿಸ್ಟಮ್ ಸ್ವಲ್ಪ ಸ್ಲೋ ಇದೆ, ಈಗ ಆಗಿದೆ ಅನ್ನೋಲ್ಲ.
No, ma'am.
ಇಲ್ಲ ಮ್ಯಾಮ್.
Still in progress. Yeah, we got now.
Got it.
Now
Okay.
it's visible ma'am.
Now it's visible. I'll
Yes,
put it
ma'am.
on the slideshow mode.
Okay ma'am.
I hope so. Is it visible now?
Yes ma'am, it's visible ma'am.
Can I go ahead with the presentation?
Sure ma'am, sure ma'am.
Right. Thank you so much for the opportunity, especially from Embry. And I also thank the earlier resource persons, Dr. Prithvish and Dr. Ramkrishna Gaud. They have made it a lot more easier for me to interact. ನಮಸ್ಕಾರ. ಕೋಲಾರ ಜಿಲ್ಲೆಯಿಂದ ಅಟೆಂಡ್ ಆಗ್ತಾ ಇರೋ ಎಲ್ಲ ಅಟೆಂಡೀಸ್ಗೆ. ಇಲ್ಲಿ ತನಕ so far Dr. Ramkrishna Gaud has spoken in terms of what the rule says and how it is being implemented. Let's look at where are our gaps. Why is it that we are not in a position to implement certain things? This is where I think you can this is something which each of the healthcare facility has to look for themselves. But I'm here to give an overview of where are the gaps which we have noticed in most of the places whenever we have gone and looked for the systems of biomedical waste management in a healthcare setup. So let's look at this. This is what I'm giving is an overall scenario. This may not be really applicable directly to your healthcare facilities, but it is nice to have a overall view of the things that are there. So when you look at it in India, you have roughly around 3,22,425 healthcare facilities. Of them, around 1 lakh and odd bedded, and the rest of them non-bedded. And the common treatment facilities that are in operation are roughly around 202. And 1,50,000 plus have received authorization. And these are the statistics which are there. And in biomedical waste management scenario in 2019, this is the quantum of the waste that is being generated, roughly around 619 tons. And the ones which are treated are roughly around 544 tons. So we are not sure what happens to this 74 tons that is being generated, but it is not being recorded as that is being treated. We are not sure whether it's being treated or it is not being treated or something else happens to this. I would request the participants not to annotate or do anything on it on the screen. So when you look at the biomedical waste management scenario in the whole of India, so this is where it is. You have certain states which have good facilities, and in certain states there are not much of facilities that are there. Especially when you look at the 6 states of Goa and Andaman, there are no common treatment facilities that are there. Here in the states which we have mentioned here, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, there is a discrepancy in the gap in the amount that is generated and amount actually that is being recorded, that is being treated. So in 2019, Karnataka has generated 77.5 tons, and number of CVWTFs, that is the common biomedical waste treatment facilities, are 27. We have been utilizing only 1/3 or 33% of the capacity that is being there. And so far the total violations is around 3,926. I'll just when it comes to COVID-19, one thing what most of us expected was the amount of waste that is generated could have increased quite a bit. Yes, it is increased, but at the same time, there are other kind of biomedical waste which had reduced because we were not catering to the other diseases. We catered only to COVID-19, and the other diseases had come. I mean, services for the others have, but later on when everything came back to normalcy, we have an increased amount. This was in December 2021 what we had. We are able to provide this because there is a mobile app where you need to record the COVID-19 ones. Now let's look at how the CPCB evaluates each of the pollution control boards. So they are looking at around 12 performance indicators where they are looked at. As per the BMW rules, if you look at, they need to provide authorization to most of the healthcare facilities. So before they provide authorization, we need to have an inventory also to find out how many have been authorized and how many have not been authorized. So inventory of healthcare facilities, authorization to all the healthcare facilities, and facilitation of common biomedical waste treatment facility in case it is necessary. If there is nothing is there, then constitution of the state advisory and monitoring committee, and implementation of the barcode, monitoring of healthcare waste management, healthcare facilities, monitoring the infrastructure, preparation of annual compliance reports and compliance with the training and capacity building, installation of online monitoring of industrial effluents and emissions and effluents. These are some of the parameters which the common Central Pollution Control Board has set to look at the working pattern of performance of the individual state pollution control boards or pollution control units. So if you look at the components of any waste management system, we have these components like the management policy, that is standard operating procedures, monitoring, record maintenance. Then you have these, we may call it as macro issues. The processes of segregation, disinfection, collection and transportation, and final treatment and disposal. And we also have the worker safety, which runs through and through all the processes. So let's look at where all we find the gaps in each of these places. Now, if you look at the management policy, that means, does the healthcare facility have a policy for waste management? Does the healthcare facility have a policy for occupational safety? Do they have a policy where they monitor the waste management processes? Do they maintain the records or not? Is something what we need to look at. So before we do that, do the personnel have knowledge regarding all these issues is one thing which we wanted to look at. So based on some of the articles, there has been some amount of knowledge when it comes to the knowledge and practice. When it comes to knowledge, most of them have scored very high. That means people are aware in terms of what sort of waste is generated and it should be segregated. To that extent they know. But when it comes to practices, the practices are sometimes not up to the mark as what their knowledge level is. So there have been gaps in terms of knowledge and practice also. But when it comes to attitude, there's a huge gap. Unless we have the attitude to be favorable among all the cadres, the gaps in practice will always be there. So when they looked at the different cadres, the gaps in practice there was a very less gap regarding practice when it came to nurses when compared to other cadres at the healthcare facilities, other healthcare personnel. So just as I said, in the components, when we looked at presence of standard operating procedures, presence of a policy or documentation processes, this has been found. This was the result what we found. So we had done a survey in 2017 as a part of a project among 4 large hospitals, 8 medium hospitals, and 19 small hospitals in the state of Karnataka. What I'm talking is of Karnataka, facilities within Karnataka. And large hospitals means these are more than 500 bedded, and medium hospitals have beds between 100 to 500, and small hospitals include non-bedded as well as up to 100 bedded hospitals. So they were selected across the state of Karnataka, and these were the number that were selected. And among these this is what is our finding. They did find the committee exists. There were standard operating procedures that were adapted, and they also had a designated temporary storage room. The workers were supplied with personal protective equipment. There was documentation in terms of registry, both injury registry as well as spill registry. Of course, in the large hospital, one hospital found it difficult to comply with most of these things. In medium sized, most of them complied with it, whereas in certain areas there were lacunae, especially when it came to temporary storage area and maintenance of spill registry. Now, spill registry is something which is a good practice. It would be nice if you can record as to what are the reasons or what were the condition which led to the spillage of the blood or body fluids that are there. Then when it comes to small also, they have been able to comply with most of the things. especially the documentation when it comes here in terms of spill registry is something which was lacking, and one more thing, the existence of biomedical waste. See, not all small hospitals require to maintain them, but it would be better if you designate one of them as a nodal officer to look after waste management systems. So when it comes to segregation efficiency, now there is a method by which we calculate the segregation efficiency. We went inside the hospitals. Maximum score of segregation was around 4. We looked at mix-up of waste in different bins which are there. Yellow bin, if there is a mix-up of waste in yellow bin, then the score was lower. Mix-up of waste in the red, blue was given 1 score. If there is a mix-up of biomedical waste in general waste category, then the score was lowest. The lowest score was given. So based on that, we calculated for each of the site at the hospital, we came down to a consolidated score for that particular hospital, divided by the number of locations that we selected and the maximum score. So based on that, we calculated the segregation efficiency. If you look at medium, one of the large hospitals did have a problem. So therefore you always find 75% being excellent. Whereas in small, it ranges from being average to excellent, but all the medium-sized hospitals were excellent in their segregation practices. Now, this is the crux of the issue where most of the gaps can arise. All right, so let's go. What are the commonly observed violations or commonly observed things? What we see is there will be a mix-up of biomedical waste and general waste. This can happen in locations, especially in the wards, where you have the placement of the bins. The general waste bin might be placed very next to the biomedical waste management bin or the yellow bin, where there are chances that the general waste can be put into the yellow bin instead of the green or the blue bin, which is for the solid waste management. Here, this is something which is quite common, where there might be a mismatch in the color code liners and containers. Container says the container is of a different color, the liner is of a different color. When this happens, I am not sure what waste should go in there, especially if you look on the thing on the left side. It is a black container with a yellow liner. I'm not sure whether this black container is meant for general waste where I can put them, or is it meant for a yellow color waste. And one more thing, there's no biohazard symbol here, even in the ones which are placed on the left side here, right side here. The color is different, the liners are different. So therefore, I'm not sure which ways to put there or how I should go about doing segregation. Now, each of us can perceive this in a different way. And poor segregation is one of the most common things which we find. You find general waste in this yellow bin. What happens if I do this? Is it such a huge issue that I should keep this segregation to such a level? Yes, it is better if we do it. If you do the mistake here, this mistake gets compounded along the route from your collection, storage, and then back to your common treatment facility. By your mistake here, you are exposing n number of people to certain hazards. We have seen people in the common treatment facility where they try and segregate the waste, especially the plastic waste, so that it can be recycled. Because of your negligence of non-segregating, there are 10 other people who are at risk for it. Are we justified in doing it? Please think it over. Now, this is one more dressing trolley, as Dr. Ramkrishna Gaud was telling, in an operation theater. At least in an operation theater, the patient is very near to that of the table, and they can design their table or the theaters in such a way that the vicinity is closed. But when you look at a ward, you have the nurses who have to go up till the patient level to give them the care or the dressing. There might be some dressing, or they might be giving some injections or an IV drip or whatever it is. what we need to look at is design your dressing trolleys in such a way that the segregation of waste can happen wherever it is being generated, even at the bedside also, so that it is easier. The only reason why this is important here is, if you delay the segregation to a point where you bring all the waste to a common point at the nursing station or some other place where the waste has been stored, there again you sit and segregate. That means you are exposing another person to it, and it is going to take a I mean, the time taken would be more when compared to doing it immediately. So one more thing, we need to see that there is no contamination that can happen, because in a dressing trolley you have sterile substances also. So you need to design it in such a way. This is one example that has been given. Probably you can come out with a better design where it is completely segregated, the sterile from the non-sterile, and it is safe enough for it to be used. Okay, this is the in the previous slide, what I needed to emphasize here is, when it is not done at the point or the bedside, when it is carried over back to a central place, that is where there are chances that there have been needle stick injuries that could happen, and there are also chances that the segregation is not maintained. For the simple reason, it gets delayed, because as soon as it gets delayed, there might be something else that is waiting for us as an emergency. As a result, this becomes a, it takes a backseat. So therefore, this is one of the most common things where to maintain segregation, it is difficulty, is because of this reason. And when it comes to transportation within the hospital premises, I'm not talking outside the hospital premises. You may have trolleys which are open like this, or overloaded trolleys where the waste literally spills out of it. I think we need to avoid such kind of transportation, that in the especially within the hospital premises also. And here you find a person without any personal protective equipment trying, though he's carrying an empty trolley, I assume that he has emptied it and then is returning back. So it's the same thing what I'm trying to reiterate. Let's see that the trolleys are closed and there's no overload or excessive load or waste that is being dumped inside the trolley, and preferably the person should be wearing the personal protective equipment. And one more thing, what we have noticed in most of the places is, especially when it comes to medium-sized and small-sized hospital, is a temporary storage area. It is mandated that you can still, as per the rules, you can store the waste up to 48 hours. But then in that 48 hours, where are you going to store it? You may not be in a position to store it very near to the patient or in the ward. So you need an area. Usually when the hospitals are constructed, this aspect is slightly not taken into consideration, and the temporary storage areas are not appropriately built. One example, what I'm showing you here, is something very similar. This is a fact, and we have seen this happening also. Even today, the storage areas will be very somewhere underneath the staircase, where anybody can everybody can access it, or it will be spilling outside the staircase, underneath the staircase. So these are some of the things which we need to keep in mind. Segregation should also be maintained even in the storage area also. So this is an example where you can find segregated temporary storage area. Now you may ask me, even for a small hospital, is it necessary for it? I would say preferably yes, because even the smallest of the smallest hospitals, you may see, at the most, the minimum is you can still maintain the color-coded bins with a lock and key, so that people will not have access to it, and have a designated area where that particular area can be cleaned and kept well ventilated, and see that there's no mix-up of waste that happens. So even in a small hospital also, it is necessary for us to maintain this segregation even at the storage point. Now, another thing what we have noticed is, many a times, especially in places where it is not, even in places where it is connected to a common treatment facility, the recyclable waste, especially the plastic waste, are collected very diligently. They make it a point to collect it and it is segregated very well also when it comes to the waste that can be income generated. but it is handed over to an unauthorized waste handler. Our suggestion is not to hand it over to an unauthorized waste handler. And even if this has been segregated very well, it needs to undergo some amount of treatment in terms of autoclave or a microwave to disinfect whatever is there, and then hand it over to an authorized waste handler. The reason why we call it, we specifically mention for authorized waste handler is that they do have certain systems in place, and the chances of pilferage or misuse of this waste is minimized. So that is the reason why we specifically mention about authorized waste recycler. And preferably open burning needs to be avoided, and also the place where we store or mixing up of general waste with the healthcare waste should not be done. What happens is when it is done, it is kind of thrown around, and you may find animals accessing it or feeding on it, which may not be a very good idea. So this is the implementation, training and retraining is what we looked at. So if we look at what I said so far is only meant is for the healthcare facilities. The other aspect of the waste management is also what happens at the common biomedical waste treatment facility. Have they implemented what the rule says? Let's look at it. Have all the common treatment facilities need to have a technology upgradation in terms of online emission tracking system. And barcoding is not just the responsibility of the common treatment facility, it is also the responsibility of the healthcare facility as well as the common treatment facility. Both of them are responsible for it. The simple reason why we talk of barcoding is tracking of waste becomes very easy. I'm sure you would have heard about a lot of other things in the newspapers telling that the hospitals have dumped the waste on the road, or hospitals have dumped it inside a water body. These kind of unnecessary and unwanted things can be easily avoided and can also be easily tracked down to say who's at fault here. And one more thing when it comes to common treatment facility is most of the common treatment facilities have incineration, an autoclave, a shredder, or a microwave in there as a treatment processes that they do. In an incinerator, for an incinerator, they have an online monitoring system in terms of the temperatures also. Both the primary chamber and the secondary chamber appropriate temperatures need to be achieved. If they do not achieve that appropriate temperatures, then there are chances that they can pollute the environment. So the Pollution Control Board has asked for an online monitoring system. So, and this is where it is important for the common treatment facility person to achieve this kind of emission standards. The segregation should be optimal. So if you think a minor mistake at your hospital is okay, that same minor mistake, this is where it gets compounded. You will have an unsegregated waste going into the incinerator, and then it brings down the efficiency of our incinerators also. This is what happened in COVID-19 waste in the initial days, where we thought everything that comes out from an isolation ward of COVID isolation ward should be dumped and it should be incinerated. So we landed up with huge amount of food waste, huge amount of waste that can be handled in a separate way into the incinerators, and thereby bringing down the efficiency and also increasing the emission or not complying with the emission standards. So therefore, any waste that you put into the yellow bin, think twice, think whether it can be incinerated or not. If it is not incinerable, please do not put it into the yellow bin. All right. So now when it comes to the regulatory authorities, we have looked at it into 3 or 4 parts. It first comes the healthcare facility, then comes the common treatment facility person, and then the regulatory authorities. For the regulatory authorities, it is definitely a challenge for them to monitor all the places, but at least a sample of places I think have been monitored. The larger hospitals are always under the radar and they are monitored most of the time. When it comes to the smaller hospitals, I think it is the individual responsibility for them to comply with the rules. So these are some of the gaps from Karnataka where regular monitoring of healthcare facilities, they say it's not in place. Submission of the reports within the deadline is not happening. Barcoding systems have not been fully implemented, and the CBWTFs have not upgraded with the new emission rules. So this is what some of the things. Now, is this all? Is just looking at the gaps isn't enough. So we need to look at how we can overcome these gaps. One is to have monitoring systems at the district level itself, so that each of those district commissions can monitor the status in their respective districts. Training and retraining, of course. How much ever we train and retrain, there's always something to learn, and there's always this training and retraining aspects should not only look at only the knowledge part of it, maybe also consider the attitudinal change among the people who are involved in it. And there's another way of monitoring is to bring in third-party audits and holding the account, the healthcare facilities, the common treatment facilities, and also accountability of them, so that they can be live. I mean, you can allow them for scrutiny, and they can allow any third person for the scrutiny of their systems in place, both the healthcare facility as well as the common biomedical waste treatment facility. And one more thing what we need to look at is, most of the time we may lack budget, but that is not a hindering factor in most of the places, because even with the lowest of the lowest budget, segregation can be done and maintained also, so that it doesn't cause a harm to person or not. Another thing is to improve the stakeholder awareness to impose the source segregation. Now, the best way to do this in a healthcare facility at the source of generation, the segregation, is to have monitoring systems in place. If you have a regular monitoring systems in place, the chances are likely that the people do follow the segregation aspect, providing incentives or disincentives depending on whatever is deemed fit. So monitoring systems at the common biomedical waste treatment facilities, and also extensive training programs and awareness programs for all the cadres, such as that would be the person who is actually involved, the doctors, the nurses, all the cadres of the people it is necessary for us to train. And stringent measures to impose environmental compensation charge by the regulatory authorities for non-compliance. These are some of the things which we thought can be solutions for it. And these are my references. And thank you for a patient hearing. Any questions?
Now participants ask questions now.
Yeah, please. They can ask any questions if they have.
Now
Okay.
this session is open for questions. ನಿಮ್ಗೆ ಏನಾದ್ರು ಅರ್ಥ ಆಗಿಲ್ಲ ಅಂದ್ರೆ ಅಥವಾ ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದ್ರೆ ನೀವು ಕ್ಲಾರಿಫೈ ಮಾಡ್ಕೋಬಹುದು, ಕ್ಲಿಯರ್ ಮಾಡ್ಕೋಬಹುದು.
Doubts ಏನಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ we can move ahead with the next
ಸೆಷನ್. ಅಕಸ್ಮಾತ್ ನಿಮ್ದು ಡೌಟ್ಸ್ ಗಳಿದ್ರು ಕೂಡ ಚಾಟ್ ಬಾಕ್ಸ್ ಅಲ್ಲಿ ಹಾಕಿ.
ಈಗ ಕೇಳಕ್ಕೆ ಒಂದೊಂದ್ಸತಿ ಇಟ್ ಮೇ ನಾಟ್ ಅಕ್ಕರ್ ಟು ಯು. ಆಮೇಲೆ ಏನಾದ್ರು ನಿಮಗ್ ಡೌಟ್ ಬಂದ್ರೂ ನೀವ್ ಇಮೇಲ್ ಮೂಲಕ ಆದ್ರೂ ನೀವು ಕಳಿಸ್ಬೋದು, ಅಥವಾ ಈ ಸೆಷನ್ ನಡೀತಾ ಇರೋದ್ರಲ್ಲೇ ನೋಡ್ಬೇಕು ಅಂದಾಗ ಚಾಟ್ ಬಾಕ್ಸ್ ನಲ್ಲಿ ನೀವು ಹಾಕಿದ್ರು ನಡೆಯುತ್ತೆ. ಹೇಳಿ ಮೇಡಮ್. ನೀವ್ ಮಾತಾಡೋವಾಗ ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಂಡ್ ಮಾತಾಡಿಮ್ಮ.
ಗ್ರೇಸ್ ಮೇರಿ ಕ್ವೆಶನ್ ಕೇಳಿ ಮ್ಯಾಮ್. ಇಲ್ಲ ಮ್ಯಾಮ್, ಅದು ಮಿಸ್ ಆಗೇನೋ ಇದ್ ಮಾಡ್ತಿದ್ದಾರೆ ಅನ್ಸುತ್ತೆ.
Okay, okay.
Okay, ma'am.
Then I think we can move on to the next
Okay, ma'am.
session.
Thank you
Right.
very much, ma'am.
Thank you. I'll
For this-
mute myself.
Thank you very much, ma'am, for this detailed deliberation on common mistakes made during segregation of waste at source and effective way to overcome this problem. Thank you, ma'am. Next, I would like to welcome our next resource person, Dr. Akshaya KM. Over to you, sir.
ಗುಡ್ ಆಫ್ಟರ್ನೂನ್ ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ನಾನು ಮಾತಾಡ್ತಾ ಇರೋದು ಕೇಳ್ತಾ ಇದೆಯಾ ಪೂಜಾ? ಆಮ್ ಐ ಆಡಿಬಲ್?
You're audible, sir.
ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು.
Screen is not shared, sir.
Yeah, I'm sharing. Just give me a second. Okay, is the screen visible now?
Yes, sir, it's visible now.
Okay, thanks Pooja. So ಇಷ್ಟರವರೆಗೆ ನಾವು ಬೆಳಗ್ಗೆಯಿಂದ we were looking in about how to go about biomedical waste management and what are the principles, segregation ಹೇಗೆ ಮಾಡಬೇಕು, ಕಲರ್ ಕೋಡೆಡ್ ಬಿನ್ಸ್ ಅನ್ನಲ್ಲಿ ಯಾವ್ಯಾವ ವೇಸ್ಟ್ ಅನ್ನು ಯಾವ್ದಾದ್ರೊಳಗೆ ಹಾಕಬೇಕು, ಅದ್ರ ಜೊತೆಗೆ ನೆಕ್ಸ್ಟ್ what are the important components of healthcare waste management. Then we saw some of the lacunae or gaps, ಅಂದ್ರೆ ಎಲ್ಲೆಲ್ಲಿ ನಾವು ಎಡವ್ತಾ ಇದೀವಿ ಈ ಒಂದು ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಅಲ್ಲಿ ಅಂತ ಅನ್ನೋದನ್ನ ಕೂಡ ನೋಡಿದ್ವಿ. Then in this particular session over next 15 to 20 minutes, we'll focus on biomedical waste management with respect to COVID-19 scenario. So pre-COVID ಹೇಗಾಗ್ತಾ ಇತ್ತು ಅಂತ ಹೇಳಿ ನಾವು ನೋಡಿದ್ವಿ. ಕೋವಿಡ್ ಇದ್ದಾಗ ಯಾವ ತರ ಒಂದು ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ನಡೀತು ಅಂತ ಅನ್ನೋದು ನಮಗೆ ಗೊತ್ತು. There were some gaps but in the initial phase of the COVID itself, CPCB came up with guidelines with respect to how biomedical waste should be managed during the times of COVID. So adana even next 15-20 minutes alli nodana now. So as per CPCB report, so Central Pollution Control Board report, India generated about 101 metric tons of biomedical waste per day, which was termed as COVID-19 waste. And ಈ ಒಂದು COVID-19 ವೇಸ್ಟ್ ಸೆಕೆಂಡ್ ವೇವ್ ಟೈಮ್ ಅಲ್ಲಿ ಪೀಕಿಗೆ ಹೋಗಿತ್ತು, ಆಲ್ಮೋಸ್ಟ್ ಡಬಲ್ ದಿಸ್ ಅಮೌಂಟ್, ದಟ್ ವಾಸ್ ಅರೌಂಡ್ 203 tons per day. routinely 609 metric tons of biomedical waste is generated across India. So ಈ ಒಂದು ವೇಸ್ಟ್ ಜನರೇಟ್ ಆಗ್ತಾ ಇರೋದು ಆಲ್ಮೋಸ್ಟ್ 25% ಜಾಸ್ತಿ ಆಗಿತ್ತು ಸೆಕೆಂಡ್ ವೇವ್ ಟೈಮ್ ಅಲ್ಲಿ. And the amount of biomedical waste generated per bed ranges from around 500 grams to up to 4 kgs also. So first wave alli, initial phase of COVID alli, India has generated almost 32,996 metric tons, nearing 33,000 metric tons of COVID waste. So based on this particular slide, you can imagine how big this particular problem was. And the month-wise generation peaked with the month where there was highest number of cases. Similarly, wherever there was reporting of higher number of cases, the average biomedical waste which was generated during COVID times also matched with that particular number. In this particular slide, you are able to appreciate that how COVID waste generation became higher during the second wave of COVID. So even the COVID time ಅಲ್ಲಿ ಯಾವ ತರ ಒಂದು ಪ್ರಾಬ್ಲಮ್ಸ್ ಬಂತು ನಮ್ಗೆಲ್ಲರಿಗೂ ಅಂತ ಅನ್ನೋದನ್ನ we can actually appreciate in this particular. So the crisis which was to be managed was across the health facilities as well as the communities. So in the initial phase of COVID, we didn't know actually what to use and what not to use. Who are the people who need to use the PPE? actually the full PPE need to be used by which set of people. So idರ ಜ್ಞಾನ ಕೂಡ ನಮಗೆ actually we were lacking, and thereby use of PPE personal protective equipment increased across all cadres of staff. So initial phase ಅಲ್ಲಿ because of the fear, because of a lack of proper guidelines, even the person who was screening the temperature, even the person who was recording the details of the patient in the triage, in the fever clinic, was using a full PPE, which was not actually required. But due to lack of guidelines, due to fear, due to some amount of apprehension, all of us used this. So in the process, use of PPE has increased across all the centers, across all the areas wherever patient was being treated, right from the point of registration, diagnosis, and later on admission. And this particular use of personal protective equipment has led to a huge quantum of waste, and there was lack of awareness about the segregation and finally what impact it could be doing on the environment. Almost 25% of our waste production increased during this particular period. And at the community level, what happened was there was generation of domestic waste, probably in the form of the masks which was being used, probably in the form of the hand sanitizers which were being used. So one thing is the containers of these particular hand sanitizers, or if it was in disposable containers, even that particular thing contributed. And how this particular waste collection could be operationalized at the household level. Even today, we are not very clear about this. Whom should we give this particular biomedical waste which has been generated at the household level? Especially when it comes to self-diagnostic kits. So self-diagnostic kits bantu, where people were able to test whether they have COVID or not, similar to what we have like malaria testing kits. So rapid diagnostic testing kits. So ee ಒಂದು waste ಅನ್ನ ಏನ್ ಮಾಡಬೇಕು ಅಂತ ಹೇಳೋದನ್ನು ಕೂಡ there were issues with respect to this. So whether it was the swab which was there in the test, whether it was the test plate which was there, so all these issues were there. And finally, the awareness in the community and was not great. It was very poor. And then we didn't know how to engage these particular communities when it comes to segregation as well as disposal of the biomedical waste generated in the community settings. I also want to tell the role of the quarantine centers or facilities which were used to put the close contacts, for example the schools irbodu athwa hostels irbodu athwa ಛತ್ರಗಳು irbodu. So ಇಲ್ಲಿ ಎಲ್ಲ generate ಆಗಿರೋ waste ಅನ್ನ how it should be collected, how it should be segregated, collected, and then efficiently managed ಅಂತ ಅನ್ನೋದು ಕೂಡ we were not really aware of this. There were guidelines, but seldom were these particular guidelines were followed. So what is this particular COVID biomedical waste? It is the waste generated during diagnosis and treatment of COVID-19 suspect or confirmed cases. So it can actually be generated right from the point where the person enters the hospital or the facility till the particular person exits the facility. So it can be in quarantine centers, it can be in isolation wards, sample collection centers, laboratories, urban local bodies, or common biomedical waste treatment and disposal facilities. So ಈ ಒಂದು waste generate ಆಗಿರೋದಕ್ಕೆ existing biomedical waste rules ಅನ್ನ ಮೇಲಾಗಿಯೂ ಕೂಡ there were some guidelines which were proposed and they were implemented later. So as I told, the sources of COVID waste can be right from the point of diagnosis till the immunization. Why this particular concern? As we all know, biomedical waste has the potential to spread infections, which includes COVID-19. And improper disposal of this particular COVID waste, especially the plastic containing PPEs, personal protective equipment, can release high levels of dioxins and furans when they are burnt. And biomedical waste management requires a life cycle approach. So right from the production till the disposal, there needs to be a scientific way of managing this. And unscientific disposal can adversely affect the public health, as well as it can be an occupational risk for the people who are handling. So, idkoskara CPCB came up with the guidelines as early as March 18th, 2020. That means the initial phase of COVID, where there were lockdowns following this. And they were subsequently revised on 25th March, 18th April, and the latest one came in 2020 July. ಇದ್ರ ಜೊತೆಗೆ ವಾಟ್ ಎವರ್ ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ರೂಲ್ಸ್ ಇದೆಯೋ 2016 ಅಂಡ್ ಅದರ ಅಮೆಂಡ್ಮೆಂಟ್ ಕೂಡ ಈ ಒಂದು COVID-19 ವೇಸ್ಟ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ಗೆ ಅಪ್ಲಿಕೇಬಲ್ ಆಗುತ್ತೆ. So this is what I have already told. We need to follow a life cycle approach for management of COVID biomedical waste right from its generation till the disposal. ಏನು ಒಂದು ಅಡಿಷನಲ್ ಆಗಿ ಇದರೊಳಗೆ ಆಡ್ ಮಾಡಿದ್ದಾರೆ COVID-19 ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ರೂಲ್ಸ್ ಅಲ್ಲಿ ಅಂತ ಅನ್ನೋದನ್ನ ಈ ಸ್ಲೈಡ್ ಅಲ್ಲಿ ನೋಡೋಣ. ಸೊ ವಿ ಆಲ್ ನೋ ಹ್ಯೂಮನ್ ಅಂಡ್ ಅನಾಟಮಿಕಲ್ ವೇಸ್ಟ್, ಸಾಯಿಲ್ಡ್ ವೇಸ್ಟ್, ಎಕ್ಸ್ಪೈರ್ಡ್ ಡಿಸ್ಕಾರ್ಡೆಡ್ ಮೆಡಿಸಿನ್ಸ್, ಕೆಮಿಕಲ್ ವೇಸ್ಟ್, ಬ್ಲಡ್ ಬ್ಯಾಗ್ಸ್ ಇದೆಲ್ಲ ಯೆಲ್ಲೋ ಬಿನ್ನಿಗೆ ಹೋಗಬೇಕು. ಸೊ ಇಫ್ ಯು ಹ್ಯಾವ್ ಮೋರ್ ದೆನ್ ಒನ್ ಕ್ಯಾಟಗರಿ ಆಫ್ ವೇಸ್ಟ್ ಇನ್ ದಿಸ್ ಪರ್ಟಿಕ್ಯುಲರ್ ಸೆಟ್ ಆಫ್ ವೇಸ್ಟ್, ವಿ ನೀಡ್ ಟು ಹ್ಯಾವ್ 2 or 3 ಯೆಲ್ಲೋ ಬಿನ್ಸ್ ವಿತ್ ಯೆಲ್ಲೋ ಲೈನರ್. ಇದು ಆಲ್ರೆಡಿ ಡಾಕ್ಟರ್ ರಾಮಕೃಷ್ಣ ಗೌಡ್ ಅವರು ಅವರ ಪ್ರೆಸೆಂಟೇಷನ್ ಅಲ್ಲಿ ಇದ್ರ ಬಗ್ಗೆ ಹೇಳಿದ್ದಾರೆ, ಅಂಡ್ ಐ ಜಸ್ಟ್ ವಾಂಟ್ ಟು ರೀಟ್ರೇಟ್ ದಟ್. ಸೊ ಸೇಮ್ ಥಿಂಗ್ ಫಾಲೋಸ್ ಇನ್ COVID-19 also. And with respect to broken or discarded contaminated glassware implants, so illu kuda we need to use the blue color bin. So illi nimge ampules ಅಥವಾ broken containers ಗ್ಲಾಸ್ವೇರ್ ಇತ್ತು ಅಂತಾರೆ, ಅದಕ್ಕೊಂದು ಯೂಸ್ ಮಾಡ್ಬೋದು. ಮೆಟಾಲಿಕ್ ಬಾಡಿ ಇಂಪ್ಲಾಂಟ್ಸ್ಗೆ ಇನ್ನೊಂದು ಬ್ಲೂ ಕಲರ್ ಬಿನ್ ಅನ್ನ ಯೂಸ್ ಮಾಡ್ಬೋದು ವಿತ್ ಬ್ಲೂ ಲೈನರ್. All recyclable plastics and gloves will go to red color bin. And metallic sharps, auto disable syringes, ivella white color puncture proof container ಗೆ ಹೋಗುತ್ತೆ. So this is important as far as whatever we are managing with respect to our vaccination or immunization, even in the periphery is concerned. What is there in COVID is put up clearly in this particular part of the slide. If the used PPE is non-plastic or semi-plastic, then it should be disposed to yellow bin with double liner. So please use a double liner for all the COVID-19 wastes which are being segregated. So ee ಒಂದು bin ಅಲ್ಲಿ ನೀವು double liner ಅನ್ನ ಯೂಸ್ ಮಾಡಬೇಕು. If the PPE is plastic, then it should be disposed to red bin with double liner. ಸೊ ನೀವು ನಿಮ್ಮ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ ಯಾವ ತರದ ಒಂದು ಪರ್ಸನಲ್ ಪ್ರೊಟೆಕ್ಟಿವ್ ಇಕ್ವಿಪ್ಮೆಂಟ್ ಅನ್ನ ನೀವು ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದೀರಿ ಅಂತ ಹೇಳಿ ನೋಡ್ಕೊಂಡು ಅದನ್ನ ಆ ಅಪ್ರಾಪ್ರಿಯೇಟ್ ಬಿನ್ ಅಲ್ಲಿ ಹಾಕ್ಬೇಕಾಗತ್ತೆ. ಸಿಮಿಲರ್ಲಿ ಯೂಸ್ಡ್ ಮಾಸ್ಕ್ಸ್ ಶುಡ್ ಗೋ ಇನ್ ಟು yellow color bin because it is not recyclable and it is not plastic, it is not gloves. So it is similar to soiled waste or contaminated waste because of human secretions. So ಈ ಒಂದು ವೇಸ್ಟ್ ಅನ್ನ ನೀವು ಯೆಲ್ಲೋ ಕಲರ್ ಬಿನ್ನಿಗೆ ಹಾಕಬೇಕಾಗತ್ತೆ. So I think everyone is clear. There is no much difference, but you need to think very rationally that you need to use 2 or double liners for each of these particular bins when you are using it for COVID waste. ಒಂದನ್ನ ನಾವು ಫಾಲೋ ಮಾಡಬಹುದು. ವಿ ನೀಡ್ ಟು ಹ್ಯಾವ್ ಸಪರೇಟ್ ಲೇಬಲ್ಡ್ ಕಲರ್ಡ್ ಕೋಡೆಡ್ ಬಿನ್ಸ್ ಇನ್ ಐಸೋಲೇಷನ್ ವಾರ್ಡ್ಸ್ ಅಂಡ್ ICUs ವೆರೆವರ್ ಕೋವಿಡ್ ಪೇಷಂಟ್ಸ್ ಆರ್ ಬೀಂಗ್ ಅಡ್ಮಿಟೆಡ್. ಸೊ ಈ ಒಂದು COVID-19 ವೇಸ್ಟ್ ಅಂತ ಹೇಳಿ ನಾವು ಅದ್ರ ಮೇಲೆ ಲೇಬಲ್ ಮಾಡೋದ್ರಿಂದ ಏನಾಗುತ್ತೆ ಅಂತಂದ್ರೆ ವಿ ವಿಲ್ ಬಿ ಪ್ರಯಾರಿಟೈಸಿಂಗ್ ದೋಸ್ ಬಿನ್ಸ್ ಆರ್ ವೇಸ್ಟ್ ಜನರೇಟೆಡ್ ಟು ಬಿ ಗಿವನ್ ಟು ದ ಕಾಮನ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿ. ಸೊ ಯೂಶಲಿ ಅಪ್ ಟು 48 hours ವರೆಗೆ ಸ್ಟೋರ್ ಮಾಡಬಹುದು ಅಂತ ಹೇಳ್ತಾರೆ, ಬಟ್ COVID-19 ವೇಸ್ಟ್ ಅಲ್ಲಿ ಆದಷ್ಟು ಬೇಗ ಇಟ್ ಹ್ಯಾಸ್ ಟು ಬಿ ಹ್ಯಾಂಡೆಡ್ ಓವರ್ better that it is handed over within 24 hours of generation. So there will be a priority also from the common treatment facilities to pick up this particular waste and take it to the common treatment facility. And as already stressed upon, operated color coded bin idre very much appreciated. ಯಾಕಂದ್ರೆ ನಮ್ಮ ಕೈಗಳನ್ನ ನಾವು ಕಂಟಾಮಿನೇಟ್ ಮಾಡೋದನ್ನ ತಪ್ಪಿಸಬಹುದಾಗುತ್ತೆ ಇದರಲ್ಲಿ. Then double layered, as I told, non-chlorinated bags, because it should ensure that there should be adequate strength and it should be leak proof. So ಈ ಎರಡು ಕಾರಣಗಳಿಂದ we need to use double layered color coded non-chlorinated bags. ಕೋವಿಡ್ ವೇಸ್ಟ್ ಅನ್ನ ಟ್ರಾನ್ಸ್ಪೋರ್ಟ್ ಮಾಡಕ್ಕೆ ಒಂದು ಡೆಡಿಕೇಟೆಡ್ ಟ್ರಾಲಿ ಅನ್ನ ಇಟ್ಬಿಡಿ. ದಟ್ ಇಸ್ ವಾಟ್ ಇಸ್ ಎಕ್ಸ್ಪೆಕ್ಟೆಡ್. ಅಂಡ್ once the trolley is used, clean the inner and outer surface of the trolley with 1% sodium hypochlorite solution or any other detergent. Preferably 1% sodium hypochlorite solution is good. Please store this biomedical waste separately in a storage room, because this is preferred. Or preferred method, another preferred method is that you can shift this particular biomedical waste right from the ICU or the ward to the directly to the transportation vehicle of the common biomedical treatment facility. Idu sadhyavagade iddalli, please store it separately so that the people from CBWTF will pick up this particular waste on a priority basis. Yes, label bins, bags and trolleys as COVID-19. Please maintain a separate record of whatever COVID waste is generated and handed over. Provide appropriate personal protective equipment to the sanitary staff or sanitation staff or the people who are involved in transporting this particular biomedical waste. Mask ಮತ್ತೆ ಹೆಡ್ ಗೇರ್ ಅನ್ನ ಆಲ್ರೆಡಿ ಹೆಡ್ ಕವರ್ ಅನ್ನ ಎಲ್ಲಾ ಕಡೆ ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ಸಾಧ್ಯವಾದಷ್ಟು ಎಲ್ಲಾ ಕಡೆ ಅವೈಲೇಬಲ್ ಇದೆ, ಹಾಗೆ ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ಅದ್ರ ಜೊತೆ ಗಮ್ ಬೂಟ್ಸ್ ಮತ್ತೆ ರೆಡ್ ರಬ್ಬರ್, ಹೆವಿ ಡ್ಯೂಟಿ ರೆಡ್ ರಬ್ಬರ್ ಗ್ಲೌಸ್ ಅನ್ನ ಕೂಡ please ensure that these people are getting this along with a plastic gown or a personal protective equipment which covers their body. So these are the basic things which need to be given to the sanitation staff. Please have dedicated staff for handling COVID biomedical waste and solid waste separately. Segregation at the point of generation is the key, and training to all the staffs involved in COVID-19 biomedical waste handling should be done. So problem ಏನಾಗ್ತಾ ಇತ್ತು ಅಂದ್ರೆ ಇನಿಷಿಯಲ್ ಫೇಸಸ್ ಆಫ್ ಕೋವಿಡ್ ಅಲ್ಲಿ ಸಾಲಿಡ್ ವೇಸ್ಟ್ ಕೂಡ ಜನರೇಟ್ ಆಗಿದ್ದು ಏನ್ ಮಾಡ್ತಿದ್ರು ಅಂದ್ರೆ ಐದರ್ ಇನ್ ದಿಸ್ ಪರ್ಟಿಕ್ಯುಲರ್ ಯೆಲ್ಲೋ ಬಿನ್ ಆರ್ ಗ್ರೀನ್ ಆರ್ ರೆಡ್ ಬಿನ್ ಅಲ್ಲಿ ಹಾಕ್ಬಿಟ್ಟು ಕಳಿಸ್ತಾ ಇದ್ರು, ಸೇಯಿಂಗ್ ದಟ್ ರೀಸೈಕ್ಲೇಬಲ್ ಇರೋದನ್ನ ಇಲ್ಲಿ ರೆಡ್ ಬಿನ್ ಅಲ್ಲಿ ಹಾಕಿ ಫುಡ್ ವೇಸ್ಟ್ ಅನ್ನ ತೆಗೆದುಬಿಟ್ಟು ಯೆಲ್ಲೋ ಬಿನ್ ಅಲ್ಲಿ ಹಾಕಿ ಕಳಿಸ್ಬಿಡೋಣ ಅಂತ ಹೇಳಿ, which was not actually right. So this particular solid waste should be segregated as per the solid waste management rules of 2016, and spraying with 1% sodium hypochlorite solution was earlier suggested. Even if it is not possible, that is fine, but it has to be segregated into wet waste and dry waste separately and handed over to the urban local body, whether it is a corporation or municipality or whether it is a gram panchayat. It has to be managed as per the SWM rules of 2016. Please minimize the use of disposable items. So especially idondu problem ಆಗ್ತಾ ಇತ್ತು ನಮ್ಮ ಕ್ವಾರಂಟೈನ್ ಸೆಂಟರ್ಸ್ ಅಲ್ಲಿ or isolation centers ಅಲ್ಲಿ, or even the centers which were designated to treat or observe the patients who had minimal symptoms or no symptoms. So inta centers ali even the solid waste management was becoming a issue in the initial phases, but please manage this as per the solid waste management rules of 2016. What are the things which you should not be doing? Do not mix general waste and COVID-19 biomedical waste, because you are indirectly contaminating that particular almost 80-85% waste of the general waste as biomedical waste. Do not disinfect yellow bag with sodium hypochlorite. ಯಾಕೆ ಅಂದ್ರೆ ನೀವು yellow bag ಮೇಲೆ sodium hypochlorite ಏನಾದ್ರು ಸ್ಪ್ರೇ ಮಾಡಿದ್ರೆ this non-chlorinated yellow bag will become chlorinated yellow bag. So in the process, you are generating dioxins and furans once it is submitted for incineration. Do not hand over COVID-19 biomedical waste without proper label. So please label these things as COVID-19 waste and do not transport it in open trolleys. So even the point in health, all these are applicable even with respect to the routine biomedical waste also which is generated. So it is more of reiteration what I am telling. ಸೊ ಪರ್ಸನಲ್ ಪ್ರೊಟೆಕ್ಟಿವ್ ಇಕ್ವಿಪ್ಮೆಂಟ್ ಅನ್ನ ಹೇಗೆ ನಾವು ರ್ಯಾಷನಲಿ ಯೂಸ್ ಮಾಡಬಹುದು ಅಂತ ಅನ್ನೋದ್ರ ಬಗ್ಗೆ ಈ ಒಂದು ಸ್ಲೈಡ್ ಅಲ್ಲಿ ಇದೆ. ಇನ್ ಲೋ ರಿಸ್ಕ್ ಏರಿಯಾ, ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಹೆಲ್ಪ್ ಡೆಸ್ಕ್ ಆರ್ ರಿಸೆಪ್ಷನ್ ಏರಿಯಾದಲ್ಲಿ ಟ್ರಿಪಲ್ ಲೇಯರ್ ಮೆಡಿಕಲ್ ಮಾಸ್ಕ್ ಅಂಡ್ ಗ್ಲೌಸ್ ಮೇ ಬಿ ಮೋರ್ ದೆನ್ ಸಫಿಷಿಯಂಟ್. ಎಸ್, ಇಫ್ ಯು ಪೀಪಲ್ ಆರ್ ವೆಲ್ದಿ ಇನಫ್, ಇಫ್ ಯುವರ್ ಹಾಸ್ಪಿಟಲ್ಸ್ ಹ್ಯಾವ್ ಗಾಟ್ ಗುಡ್ ಸಪ್ಲೈಸ್, ಕೊಡ್ಬೋದು N95 ಮಾಸ್ಕ್ ಅನ್ನ, ಬಟ್ ಟ್ರಿಪಲ್ ಲೇಯರ್ ಮೆಡಿಕಲ್ ಮಾಸ್ಕ್ ವುಡ್ ಬಿ more than enough. Then in moderately risk areas such as laundry, CSSDs, N95 masks and gloves. In high risk areas, whether it is a lab, critical care area or designated COVID wards, full complement of PPE, goggles, face shield, mask, gloves, coverall or gowns, head cover, shoe cover. So idella mandatory agirutte. But yes, this usage of all these has also come down with the advent of third wave, where we all are feeling that all of us are protected either directly or indirectly from this particular COVID-19. But yes, we don't know what can happen in future. So in this particular scenario where we are not very sure about the future of COVID-19, it is better that these things are used, especially in the high risk areas. So COVID has underlined the importance of biomedical waste management. However, there is a need to be strengthened with respect to biomedical waste in the COVID scenario. Yes, attitude has changed to certain extent. There is now definition and clear definition of COVID waste. And we stick on to the 3 principles of 3 R's: reduce, reuse and recycle. And with respect to CBWTFs, there is a need to augment the facilities and the coverage of these facilities to cater to COVID waste management. So what are the learnings from COVID pandemic? Follow the guidelines of Central Pollution Control Board or the national regulations. Treat coronavirus waste as any other infectious waste. Segregate the waste at source. Dispose in a foot operated bin with a suitable color coded liner. And double layered liner should be used over here. Proper handling, collection, transportation and storage, and use of appropriate PPE. One thing what people have learned over the last 2 years is hand hygiene. So that is one of the another learning. And centralized treatment facility using autoclave and microwaves, especially for contaminated waste with COVID-19, has come into the picture. There have been some advanced techniques which have come into the picture also: hybrid steam systems, microwaves, and disfigurement of used masks and other PPEs should be done. And it is, if you are not doing, please disfigure the masks once they need to be discarded. And routine disinfection and cleaning protocols of waste bin needs to be carried out. So with 1% sodium hypochlorite. Yes, so biomedical waste management in the COVID scenario also happens to be an occupational safety issue. It is an environmental safety issue. It's an attitudinal issue, and also in the larger domain, it happens to be a patient safety issue too. So please manage COVID-19 waste as any other infectious waste, but ensure that you are segregating this in a double layer liner in the container, plus label these containers as COVID-19 waste. So these are the things which you need to remember at the end of this particular presentation. So there are videos on biomedical waste with respect to the routine biomedical waste as well as on the COVID waste. So you can have a look at these particular videos later. So these are the references. So that's the end of my presentation, and now we can actually take up certain questions if there are any. Thanks, Empri, for having given me this particular opportunity. Yeah, thanks once again.
Sir, one
Yes.
question is there, sir, in chat box.
Yes, I will have a
How
look.
to-
1 second.
How to segregate cannula with plaster?
Yes, who has asked that?
It's mobile ಏನೋ ನೇಮ್ ಇದೆ ಸರ್, Oppo F5 6GB. ನೇಮ್ ಇಲ್ಲ ಸರ್.
Okay. Yeah. Cannula with plaster needs to go into the sharps. You- Yes, cannula with plaster needs to go into the sharps. You need not take out the plaster, because in the process of you taking the plaster, there can be pricks with that particular cannula. So please avoid that, or your hands may get contaminated with the blood if it is sticking to this. So please avoid that. So it can go into the white container, puncture proof container. Hope I've answered that question. Any other thing?
ಪಾರ್ಟಿಸಿಪೆಂಟ್ಸ್ಗೆ ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದ್ರೆ ಅಥವಾ ಏನಾದ್ರು ಕ್ಲಾರಿಫೈ ಮಾಡ್ಕೋಬೇಕು ಅಂತಿದ್ರೆ ಕ್ವೆಶನ್ಸ್ ನ ಕೇಳ್ಬೋದು.
Yeah, one-to-one questions ಅನ್ನ ಕೇಳಬಹುದು. ಜೊತೆಗೆ you can also put it in the chat box. Even that is also fine.
ಅಥವಾ ನಿಮ್ಮ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ ಅಥವಾ ಬೆಸ್ಟ್ ಪ್ರಾಕ್ಟೀಸಸ್ ಏನಾದ್ರು ಇದ್ರೆ ಆ ತರದ್ ಏನಾದ್ರು ಶೇರ್ ಮಾಡ್ಕೋಬಹುದು ಡೀಟೇಲ್ಸ್.
ಅದನ್ನು ಕೂಡ ಶೇರ್ ಮಾಡ್ಕೋಬಹುದು. So Mrs. Sudhamani tells that share the PPTs. Yes, we will share the PPTs. Please write to the Empri. Empri team can share their email ID. We will share all the presentations. So ಈ presentations ಮುಖಾಂತರ ನೀವು ನಿಮ್ಮ ಹಾಸ್ಪಿಟಲ್ಸ್ ಅಲ್ಲಿ, ನಿಮ್ಮ ಹೆಲ್ತ್ ಸೆಂಟರ್ಸ್ ಅಲ್ಲಿ, even if it is a veterinary institute or a hospital also, you can train your staff or the employees who are handling these particular healthcare waste. So you can use these presentations and you can train them. So if somebody has not attended this, and if you want to train a set of employees or sanitation workers who are involved in this one, so ಅವರಿಗೆ key points ಅನ್ನ ಹೇಳ್ಬಿಟ್ಟು ಈ ಒಂದು presentation ಅನ್ನ ಯೂಸ್ ಮಾಡಿ key points ಅನ್ನ ಹೇಳಿ summarize ಮಾಡಿ ಅವರಿಗೆ.
ಸರ್ ಮನೋಹರ್
segregation ಅಂದ್ರೆ ಏನು?
ಕೇಳ್ತಾ ಇದ್ದಾರೆ ಸರ್.
Yes.
Autoclave process for pre-treatment process, and also what kind of liner we have to use?
What kind of
Liner.
Liner for what? I mean, not.
Sir, that is for, like if you want to disinfect any biomedical waste, sir said, for autoclave we have to do like that, sir said. So if you want to put any waste into the autoclave bin, and what kind of liner we have to use? Whatever the liner we are using it is 50 micron thickness will be there. If you put directly into the autoclave, will it be resistable to the heat?
No, sir. Mr. Manohar, this is Dr. Suman here. You have separate autoclavable bags.
Yes, ma'am.
You have to put it into the autoclavable bags and then autoclave it and put it into the respective bins, sir.
Okay, ma'am. So altogether, that it is like a lock zip lock cover, or else
Yes,
what is the what is the this thing, the thickness of that liner, ma'am, the material.
I'm not sure about the thickness, but what I understand is you get separate bags for autoclaving. So you first need to autoclave the waste and then put it into the respective yellow or the red.
Okay, ma'am. Thank you, ma'am.
And the autoclave has to be separate.
Yeah, ಯಾವ ವೇಸ್ಟ್ಗೆ ಪರ್ಟೈನಿಂಗ್ಲಿ ನೀವು ಕೇಳ್ತಾ ಇರೋದು? ಇಟ್ ಇಸ್ ಪರ್ಟೈನಿಂಗ್ ಟು ವಾಟ್ ವೇಸ್ಟ್?
Pre-treatment of waste, Akshay. That would be all laboratory waste, blood bags.
Okay, fine.
These have to be pre-treated and then.
Yes, sir. It's about pre-treatment process, sir, for yellow and red.
Okay. Yes, fine. So any other questions? Madam, since you are there, I think that cannula with plaster, I have answered it satisfactory. Are there any other things which I need to tell
No,
with respect to cannula and?
Cannula is like what? I mean, is it the IV
It's
cannula?
a sharp. Yes,
Nowadays
yes, it's
you-
IV cannula.
Nowadays you get, actually, if you remove the needle, you have, that is basically a plastic material.
Okay.
The intracath what they use,
Okay.
when they insert it, it is actually plastic. The needle would have been removed long back when they do the procedure itself, IV. So the
Okay.
that needle
So
can
that
go
should.
into the white one, and the plastic cannula what
Ah.
comes out can go into the red bin directly.
Red.
including-
Red.
Yeah.
Okay. So if it is, if it is plastic, then red bin. If
It
it
is
is a
not,
metal one, then
goes into the metal shaft. That is the punch-proof container.
yes.
Yes.
Yes. Any other questions?
Thank you so much, sir, for this detailed deliberation on common biomedical waste management in context of COVID-19 scenario. Thank you, sir.
Yeah. Thanks a lot.
Now I would like to welcome our next resource person for the next session, Mr. Manoj Kumar, COVID-19 BMWM mobile application software developer, technology leads and knowledge lens. Over to you, sir.
Are you able to see my screen?
Yes, sir, it's visible.
So good afternoon all. So yes. So to meet out the discrepancies in terms of the data and visualizations of the COVID biomedical waste, so we have been developed an application in help of CPCB and NGT. So the main reason of this application is to make sure that all the hospitals followed by CPWT, they have to make sure that the COVID related data is almost traceable and they kept it aside. Okay. And what they would saying is like all the hospitals who were there in this corresponding city or town, they have to make sure that data is surplusly entered and it is being accepted by the CPWT. In this entire process, there are generators, there are waste handlers, we call them as truck records, then we have a CPWT, then we have SPCBs. Everyone has to ensure that they do their job as defined by the scope of work. So now registration in the sense like as soon as all the hospitals download that application, so they will click on the register. Once they click on the register, they will enter the data and it will go to some other thing. And they will specify to which CPWT of theirs. Based on that, so trucks will be automatically configured and the same will be populated to the truck drivers and the same details will be automatically coming to the CPWT. Now the data is coming and everything is fine. The verification process involves one second, there is some. So verification process should be involved by CPWTF followed by SPCB. So they have to ensure that they do the data cleanup properly and they will take it out. So this is a generator screen. where you find out this, there is a login button. Once you click on login, you will get a registration. Once the registration is done, you'll be getting username, password to the registered email. Using that, you will be entering into the app. Once you enter, you will be landing on this page where you can click on handover. Clicking on handover, you will be landing onto this screen where you can fill the data with reference to the color backs and all. The data is circulated to this one, in the sense the server. From there, everything will sort it out. So here there is something called as personal information where you can see, and if you're not happy with the language which is usable, you just click on using change language, and you can still do that. So now hospital has entered data. Now the second headache comes for the transporter to accept the data. So assume that in Bangalore we have 2 hospitals. For all 2 hospitals, only CPWTF is 1. So since it is clearly mentioned that all CPWTF has to make sure that they keep a dedicated vehicle, that vehicle is indirectly mapped with our CPCB network. So all the details will automatically pop up. So that truck driver went to the field and he selects his username and password, and we entered. By default, he'll be getting the username password which is coming from the screen. So just he has up the waste. If you find any deficiency, he'll update it. If not, he will directly go for it. Okay. Now CPWTF will also use his application. He will also enter. He will select the vehicles to whom it is got on the track today is there. So this he'll select that particular vehicle. He'll see how much of waste it is received. That waste will be sent to the server directly, with including how many trips it has done, how many things it has been done. So now the data is coming on the ground level, where the data has to be fabricated in terms of higher level. In the sense, the approval is a key concept over here. In this approval, we have been monitored with 2 ways. One is the CPCB approval as well as SPCB approval. The CPWTF approval, we are classifying that approval into 3 bases. First, everyone has to ensure that the data which they are marked is compulsory, followed by the bifurcation and all. And SPCB has to cross-check the total number of districts that within the state is meeting up or not. For that easy convenience, we designed this web page. So the change in the web page is like hospitals and the truck drivers are not allowed, whereas CPWTF and SPCBs are allowed to take care of it. Once this is done, trucks on the field, truck trip counts, total number of waste collected, total number of bags, everything can be visible out depending on the thing what they are owning it. So there is a real-time data screen as well, where you can see the real-time data which is coming from the hospitals, data structures, all those things in this coming, so that SPCB and CPWF can easily monitor what is the data surplus is coming. Okay. So now once the ground level data came, the data is coming to the dashboards and the data is coming to the other phases as well. Now what is the next step? The next step is a verification. Since all the CPWTF is the segregation authority and SPCB is the approval authority, they have to make sure that the data is being verified. For that, what they have to do is, there is a section called as approval. They select the approval section, select the corresponding date. Just on selecting, it will come as in submit. Just approve and submit. Your cell will be there. Same thing applies for the CPWTF. So only right now all the data is automatically coming from the mobile app, but whereas both the CPWTF and both the SPCBs are failing to do the verification process. So this is how there is an evidency, and this is a mobile app, and this is the iOS application name. So you may find all those details in the website as well. I think Kohler. Do you have anyone from Kohler? I think I used to interact with him when we have issues. If it is on the call, it could be more helpful to justify. Is he on the call, Pooja? Hello. Anybody from Kohler?
Sir, yes, sir. Please tell me, sir. This is Manohar.
Manohar from which one? Like CPWTF or?
No. This is from district health office, and this is a district quality consultant, sir. Tell me, sir.
Okay, so I hope on Kohler you have CPWTF. What is that name? KGF?
Samira Hospital.
Hello.
Sorry,
Hello.
not this
Manoj
one.
sir.
Mira
Hello,
sir, Mira
Manoj sir.
Infotech.
Manoj sir.
Sir,
Yes,
Mira
sir.
Infotech.
No. Some Reddy
Ah,
used
ah.
to contact me for.
Yes, yes, Brahmanand Reddy.
Manoj.
Okay.
Manoj sir.
Yes.
Hello.
Sir,
Hello, Manoj sir.
can you please stay? Brahma is speaking. Yes, Brahma. Hello.
Hello.
Ah,
Sir.
you use the application daily basis, right?
Yes, yes, sir.
Okay, so you used to call me when you have some doubts. Okay, so I am not getting your call since 2 months, so I'm just checking. Are you updating the application properly or not? That's it.
Yes, sir. Now we have only 1 or 2 hospital is there. So that only.
Okay, so there is no right, nothing.
Yes, sir. Yes,
However, you
sir.
have a good number of credits. So
Yes, sir.
okay, so please use the application as it is. Like
Yes, sir. Yes, sir. Daily
please
we
try to-
are using.
okay. Please try to onboard the information, okay, into the system. Okay. So is there any doubts in terms of using application or any hospitals where they have not registered in the Kolar jurisdiction and they are not reporting the waste, something like that? Hello, Pooja, is there any doubts? Are you on the call?
Hello.
Yeah, who is this?
Shomurthy, Deputy Environment Lab, sir. KSCB Kolar.
Yeah, good afternoon, sir.
Yeah. Actually, we have one unit in that is a common biomedical waste. Mira.
Yes, sir.
Yeah. They are doing properly now. So almost all.
Okay.
So
any issues, sir? Like as per the thing is, like all the COVID related hospital has to be onboarded into the system. So I hope in the Kolar anything.
Manoj sir, initially they don't enter the CPCB app. After that, all are entered.
Okay.
Now only district hospital generated a very small quantity by COVID waste.
Okay. Okay. Sir.
Okay.
Okay.
All quarantine centers and this is closed now.
Okay.
Okay.
Thank you very much. So I hope.
Okay, thank you.
Pooja, are you there?
Tell me, sir.
So you just share my number to in the chat boot so that they can interact.
Sure, sir. I will share now.
Okay. Thank you very much.
hello. ನಮ್ದ್ರಲ್ಲಿ ಸ್ವಲ್ಪ ಅಮೌಂಟ್ ಶಾರ್ಟ್ ಫಾಲ್ ಅಂತ ಬರ್ತಾ ಇದೆಯಲ್ಲ ಅಮೌಂಟ್ ಮತ್ತೆ ಎರಡು ಅದು ಇದಾಗಿದೆ ಮಾರ್ಜಿನ್ ಡಿವಿಎಸ್ ಲ್ಯಾಬ್ ಬ್ರಿಡ್ಜಿಂಗ್ ಆಗಿದೆ ಅಪ್ರೂವ್ ಆಗಿದೆ ಶಾರ್ಟ್ ಫಾಲ್ ಏನ್ ಪ್ರಾಬ್ಲಮ್ ಇಲ್ವಾ ನನ್ನ ಅಕೌಂಟ್ ಅಲ್ಲಿ ಆ ಥರ ಏನಿದ್ರೆ ಹೇಳಿ ಮುಚ್ಚ
Manoj sir, I just shared your number, sir. Hello, Manoj sir. Manoj sir, are you there?
You're calling me like Manohar or Manoj, ma'am?
Manoj.
Manoj, okay, fine.
Thank you. I just shared the Manoj sir number. If anyone wants, they can copy the number. And participants, please fill the feedback form. The link is in chat box.